AB is good. All right. Ladies and gentlemen, welcome to the first of 8 OBGYN sessions. This is a 2-sequence session. We will have obstetrics tonight and tomorrow. And the reason I'm not doing 4 hours in a row is because I am leaving for Norway for a couple of 3 weeks. Very sorry about that. And then when I get back from Norway, then we will finish the 2 hours of, or 2 evenings of OB. And then I think the gynecology comes maybe a few weeks after that. Anywho, let's go ahead and start. This is me, and I am professor of OBGYN, School of Medicine, Loma Linda University, Loma Linda, California. It's about 60 miles east of Los Angeles, and the temperature right now is about 92 degrees Fahrenheit. Hey, this is crazy. You don't need to turn off your mobile phone. You don't need to put your cell phone on vibrate. This is only for the live lectures. I was in New York doing a Step 2 course a few weeks ago, and Dr. France, you would remember this. They had an Easter bonnet parade on 5th Avenue. Isn't this an amazing hat? Just unbelievable. And you ought to have seen some of the other stuff that they had. Anyway, very interesting. You may wonder about my name, Sakala. It is an Estonian name. This is Estonia right here. This is Norway we're going to go, and this is Finland over here. I'm sorry, Finland is over here. Sweden is here. Estonia is one of the 3 Baltic countries, Estonia, Latvia, and the third one down here is Lithuania. So that's where my relatives and my ethnic origin is. Sakala is really quite an important name. This is a map of ancient Estonia, 1224 AD, and right here you can see Sakala Ma. This is a county, Sakala County, and that's where I guess my relatives came from, way back. However, I was born in the UK, right there in the town of London, and this is Tower Bridge in London. When I was 8 years old, I left London and moved to Canada, to British Columbia. Maybe some of you are in Canada right now. I took my high school and other schooling in Canada, and then moved to the United States for my upper education, and have remained here since. This is in Bermuda, the island of Bermuda. If you don't obey the law, this is what they used to do to you. But I was obeying the law, even though this picture. This is an OB patient that I had a while ago. Very colorful, lots of different colors in a rainbow, I guess. This is me with the academic colors of OBGYN. This is forest green. Maybe some of you will become obstetricians gynecologists, and you will wear a gown like this when you get your board certification. And this is my wife and I on a cruise. We were going through the Panama Canal. Very, very fun. Lots of fun things there. This is Loma Linda University Medical Center. You can see it is in the San Bernardino Valley. Here are the mountains when there is snow, which there is no snow right now. It's a 800-bed tertiary care center. This is the San Bernardino Valley and the San Bernardino Mountains. Okay, over the next many days and evenings, mostly, I hope you will do active listening with your ears, you'll do active seeing with your eyes, you will do active writing with your hands. active listening to my words and cases and stories and jokes, active seeing the text on the screen, the text in your notes, images, photos, video clips, and active writing, underlining, highlighting, and that's very helpful because you have to think before you put the color in, and that makes the crease on your cerebrum. All right, the notes are very good. They are excellent. They have lots of colors on them, lots of pictures. You know why I know that they are very good? Because I wrote them. That's why I did. Anyhow, there's lots of tables, lots of good stuff that I think you will appreciate. This is a image from the notes, but let me show you what I do with it with my PowerPoint. Okay, this is what I do for a hobby, and hopefully it'll help your learning. In the margin of the pages, there's all kinds of hundreds of what I call triads. Obstetric triads, gynecology triads. This one is for ectopic pregnancy. This one is for human chorionic gonadotropin, HPL. Take time, read these through. They may be helpful on the exam. You should all have downloaded the handout because we're going to use that starting tonight. This is my algorithm for early pregnancy bleeding. And you see it's got a little box down here. This is going to be very important because these tell you what are the 2 things you need to do in order to answer any question with early pregnancy bleeding. Speculum exam, numero 1, numero 2, vaginal sonogram. We'll talk about that. This is an algorithm for fetal demise, and down here are the 5 questions you need to ask. If you're a visual learner, I think you will learn very well because I've got a lot of visual stuff for you. My 2 goals. My minimal goal is that you will pass the USMLE 2, and I have no question about that, at least as far as OBGYN. My maximal goal is that you will achieve the residency of your choice. In order to do that, you need to get a high score. And I will do my best to see if we can get you a high score. Read, if you can, ahead of time, and I'll tell you about how much we're going to cover each evening. And it'll be helpful then, because when you hear it, it won't be for the first time. All right, this did not turn out as well. These pages, or these days got all screwed up here. But let's just put it this way. For the 4 evenings of OB, we will be covering 33 pages per day and 8.2 pages per hour. So for the first, tonight, we will cover from 1 to 3 or 4. On the second, we will do from 4 or 5 to 8, and then 8 or 9 till 12. And then, anyway, if you just count 8.2 pages per hour, you can work your way through the pages in the book. Now, you should all have the book. Do you have it? Yes? Wunderbar. This is what your handout should look like. Okay, there should be 4 to a page, and the OB should have 11 pages. I hope you have that. Okay. This is my daughter about 40 years ago, and this is her daughter now. This is another granddaughter that I have, and this is her 10 years later. She is a cutie. Yes, indeed. Okay, I want to ask you to tell me about yourself, and Maggie, if we can put our voting pod down here. Okay, so if you would click A if you're female, B if you're male, and hopefully you're not unsure. So, So far, let's see, how many people do we have voting? It doesn't say how many, but I hope you are voting. It looks like we have mostly women. 2/3 are women. Okay? Next question. How old are you? Oh, just a sec. Let me broadcast so you can see. It was about 66 and about 30. Okay, so let's clear that up. And the next one will be how old are you? And here are the ages. And it looks like 2/3 are going to be 25 to 30. Okay? Next, what is your marital status? You know, the reason I'm asking you these questions is because I can't see you. I can't talk to you. You can't look. Well, you can see me, but I can't get any feedback except through the keyboard. Okay. Mark wants to see, your wife wants to see the grandkids again. All right, let me just show you real quick. This is my daughter. This is my granddaughter. And this is Quinn when she was 3 years old. And here she is, 13. So, Mark, I hope your wife enjoyed that. All right, let's go now to marital status. Let's clear this out. And single, married, divorced, not sure. And what do we get? Wow, this is really interesting. We had about 2/3 women. We had about 2/3 were 25 to 30. And it looks like the majority are married. I think I have just one more question to ask you. And that is, where did you get your training? Let me just clear this off here. Canada, A, United States, B, Caribbean, South America, C, Asia, D, and Europe, E. And it looks like Caribbean and South America and Asia is taking the lead. Okay. Very good. Oh, let me ask you this. Let me clear it off. Where are you right now? Are you in Canada, United States, Caribbean, South America, Asia, or Europe? Where are you? Okay, we got some in Canada. The majority are in the United States, some in Caribbean, South America. Okay. All right. I think that should do it. Oh, what's your area of medicine? What's your interest? Primary care, A, OBGYN, B, surgery, C, D, emergency radiology, ophthalmology, the hard ones to get into. Okay, so we got the majority primary care. That's about what I'd expect, around 50%. And D, we've got some people who are going for the big guns. Bless you. And I hope it works out for you. All right, and I think that should do it. Oh, this is a femur. This is the head of the femur. We can take the voting pot away, Maggie. Okay. What do you see here? Looks like a fracture of the neck of the femur. You know whose femur this was? It was my femur. This is about 2 years ago. And here is my new femur. And I'm doing quite well. Thank you very much. Very grateful for that. All right, and I think that's all. Okay, Maggie, if we can go to the basics A. It should be Reproductive Basics A. Okay, this is it, part 1. All right, let's go. By the way, we'll take a break on the hour for 10 minutes. So the break will be on the hour, and we'll take a 10-minute break for your potty or your whatever needs. Okay, let's start with some review. Physiology of reproduction. This is a placenta. It is one of the most wonderful organs that the human organism has, and yet what do we do with it? We Throw it away. Throw it away. Crazy. Now, some people, they will freeze dry it, and they will eat it. Tom Cruise ate it, I think. These are just a few of the placental hormones. The placenta is marvelous. It is the lungs of the fetus. It is the GI tract of the fetus. It is the renal system of the of the fetus. It has so many things. But I want you to look at just 4 main hormones. HCG, which stands for human chorionic gonadotropin, HPL, which stands for human placental laxogen, and progesterone, and estrogen. Now, what happens to these hormones through the course of pregnancy? And what I want you to notice is HCG peaks at around 9 to 10 weeks, then it drops down, levels off around 20 weeks. HPL, however, continues to go up. Progesterone, the same. Right from the beginning of pregnancy, it goes all the way up until when the placenta comes out, and then it falls. Estrogen also rises. So HCG is unique in that it peaks at around 9 to 10 weeks. All the rest go up, up, up. All right, beta-HCG. It can be either a qualitative test, which is yes or no. That can be done on the urine or the serum. Which is cheaper, the urine or the serum? The urine. So if all you need to know is yes or no, if there is no urgency, then on the exam I would order a qualitative urine. But if you need to know the titer, the quantitative, that can only be done on the serum. That's going to be more expensive, but if you need it, you need it. There are 2 main reasons we do a quantitative. What would those be? Let's see what your... Okay, number 1, Namrita, ectopic, and Claudiu, molar pregnancy. Very good. Excellent. Okay, the HCG has an alpha subunit and a beta subunit. The alpha subunit is shared with LH, FSH, and TSH. The beta subunit is unique for trophoblastic tissue. So when we have HCG that goes up, it will be both the alpha subunit and the beta subunit, but the beta subunit is what we need to know in terms of the placenta. But let's look at the LH, FSH, and TSH effect. This is the alpha subunit, the structural appearance, and this is the beta subunit, and don't they look pretty nice together? You can see the conformational appearance. All right, the beta-HCG is similar to LH, FSH, and TSH. We talked about that. LH, if you have high levels of beta-HCG, it can stimulate the same thing as LH does. If you have high levels of beta-HCG, it can stimulate FSH. And so how does that work? The LH part is used with in vitro fertilization. If you want to stimulate ovulation before you do egg retrieval, you will give a burst of beta-HCG. In a molar pregnancy, if you have very high levels of beta-HCG, the alpha subunit part will stimulate the follicles into theca-lutein ovaries, large, huge ovaries. We'll talk about that later. Patient who has molar pregnancy can appear as a hyperthyroid state, and the reason for that is the alpha subunit of the HCG can act like TSH. So, those are the 3 which are very similar to the beta-HCG. The purpose of beta-HCG is to maintain the corpus luteum. What does the corpus luteum produce? What hormone does the corpus luteum produce? It produces progesterone. And in order for the corpus luteum to continue producing progesterone, in order to maintain the pregnancy, we've got to have beta-HCG. If there's no beta-HCG, the corpus luteum says, what's the point of me hanging around? And it starts to involute, and we have lowering levels of progesterone, and then we have the menstrual period. If you have very high levels of beta-HCG, you think of twins and molar pregnancy. If you have low levels, you think of ectopic pregnancy or abortion. Everything which I'm telling you, which is in these slides, is in your notes. In your notes. All right, where does beta-HCG come from? It comes from the syncytial trophoblast. This is the very early embryo. It is a 2-layer embryo on the second post-conceptional week. The the cytotrophoblast is this layer right here, and you can see the cell walls. The syncytiotrophoblast, which is the advancing layer, as the blastocyst invades into the endometrium, it has no cell walls. It is a syncytium, and it produces the HCG. So that's important. It is a syncytiotrophoblast which produces HCG. This shows a little bit more clear that the peak of beta-HCG is around 9 to 10 weeks, and then it drops down and it levels off at around 22 weeks. The important point with this is a normal value at 9 to 10 weeks may be an abnormal value at 22 weeks. They're not the same. Now, if you have a normally progressing, growing pregnancy, placenta, the beta-HCG values should be rising. How rapidly should they rise? They should double every 2 to 3 days. Alicia, you're right, every 2 to 3 days. Now, if the levels fall like this, that is never good. That's going to be an unsuccessful pregnancy. It could be an ectopic pregnancy. It could be a spontaneous abortion, which is going to take place. HPL, human placental lactogen, can be thought of as the fetal growth hormone. It has an interesting effect on insulin. It has an anti-insulin effect. It creates insulin resistance. And when insulin resistance occurs in a genetically predisposed woman, her blood sugars may start to rise. Brings extra glucose to the baby. The baby is essentially stacking all the time. And so it gets bigger and bigger, muy grande, and it turns out to be a macrosomic baby. That is the basis, the pathophysiology of gestational diabetes. We'll talk more about that later. But that is from HPL. HPL is similar to human growth hormone. It is similar to prolactin, and the purpose is to enhance the movement of nutrients into the cell. Lipids, proteins, carbohydrates. That's how it works. Levels of a normal placenta should be rising all the way through. We talked about that. If the levels are falling, the placenta isn't doing what it should, and you may very well have an IUGR, intrauterine growth restriction. We'll talk about that later. Progesterone, that is made from 2 words. Pro, which is in support of, gestation, in support of the pregnancy. So progesterone is a hormone which is supportive of the pregnancy in a number of ways. Where is progesterone produced in the nun, her corpus luteum? After she ovulates. Remember, a corpus luteum can only exist if ovulation takes place. So a woman who is anovulatory will not have a corpus luteum, and her progesterone levels will be very low. Where is the source of progesterone in the first 7 weeks of pregnancy? It is from the corpus luteum. So if you remove the corpus luteum early in the pregnancy, it's going to be a lost pregnancy. Patients who have in vitro fertilization will be given progesterone vaginal suppositories in order to maintain the pregnancy. At what point can you stop the progesterone suppositories because the placenta has taken over the production of progesterone? And that is after 10 weeks. So in the first part of the pregnancy, it is the corpus luteum that produces progesterone. After 10 weeks, the corpus luteum will involute and it will atrophy because it's not needed anymore because the placenta is producing the progesterone. Now, estrogen. This is in your book, and there are 3 main estrogens. There is estradiol, estriol, and estrone. Estradiol, estriol, and estrone. Estradiol is the dominant estrogen in the non-pregnant reproductive years. It is produced by the ovarian follicle. and it is specifically the granulosa cells in the follicle. Estriol is the dominant hormone during pregnancy, and it is produced by the placenta. Actually, what happens is there are adrenal DHEAS, dihydroepiandrosterone sulfate, which is produced by the huge fetal adrenal. It crosses into the placenta. The placenta then converts that androgen into estrogen. And this is true of all estrogens. Estrogens arise from the aromatization of androgens. And that you should know for the exam. Estrone is the dominant estrogen after menopause, and it is produced in the adipose tissue. The adrenal steroids are converted with the aromatase enzyme in the adipose to estrone. So if we have a woman who has a very generous body habitus, who has a high BMI postmenopausally, what is going to be her level of estrogens? It's going to be very high levels of estrone because of her peripheral adiposity converting the adrenal steroids into estrone. And that increases her risk of a certain gynecologic cancer. What gynecologic cancer would be increased in these women? And it would be endometrial. Exactly, endometrial cancer. All right, this is a structural formula of estrone. You can see one hydroxyl group, estradiol, 2 hydroxyl groups, and estriol, 3 hydroxyl groups. HCG, HPL, progesterone. That's going to be in your margin of your notes. Okay, let's look at specific organ changes with pregnancy, and there is almost no organ which isn't changed by pregnancy. Here we see stretch marks. 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 Will they go away? Unfortunately, they probably will not. They may change into a more silvery color. The stretch marks, I think, are probably a genetic predisposition. If your mother doesn't have them, if your sister doesn't have them, you probably won't get them either. Some patients will get them in the first trimester. Some patients can have twins or triplets and never get stretch marks. Spider angiomata. This is because of the vasodilatation effect of estrogen and progesterone, and if you press on this, what will happen? It will blanch because the capillaries will be emptied, and then they'll fill up again. After the pregnancy, what is over? What happens to this? It goes away. It's the vasodilatation of pregnancy hormones. There's increased blood flow to the fingers and to the hand. Palmar erythema, very common in pregnancy. Gingival hypertrophy. It can look similar to what you would see with anticonvulsants. They can do this. When she brushes her teeth, she can have some bleeding from the gingival hypertrophy. The linea nigra is the increased pigmentation on the midline, which you can see very nicely here. This is more in women who have darker complexions. This also will not go away. It typically will stay there. Some women will get it on their face. They call this chloasma or melasma. Interesting, oral contraceptive pills can do the same thing. All right, now we come to where the real interest is, the cardiovascular, because many of these changes of pregnancy are to enhance the utero-placental fetal blood flow. This is in your book, in your notes, but what I'm going to look at is the blood pressure, the systolic blood pressure. What happens to it? It goes down. What happens to the diastolic? It goes down even more. Both go down, but the diastolic goes down more. So we have a decrease in the arterial blood pressure. The venous pressure, the central venous pressure doesn't change, but the femoral venous pressure goes up. Those parts of the body below the waist, you will have an increase in the venous pressure. Peripheral vascular resistance will go down as well. And these are probably a function of the vasodilation effect of progesterone. After the pregnancy, they'll go back to what they were before. Here you can see the weeks of the pregnancy, 8 weeks, 16 weeks, 24, and so on. And this vertical red line is the first trimester. And here you can see what happens to blood pressure. Normally, it will come down and down and down. Lowest point will be around 24 to 26 weeks, and then it will come back up, but it never goes higher than it was to begin the pregnancy. The same thing with the diastolic, but the blood pressure drop is even more. But notice the blood pressure at the end of the pregnancy is never higher than it was in the beginning. So the take-home message here is blood pressure is never normally elevated in pregnancy. Femoral venous pressure is different. You can see it goes from 9 to about 25. It's almost a threefold increase in femoral venous pressure. Now, the result of that is varicose veins and hemorrhoids. And here you can see a variety of different women with varying degrees of hemorrhoids, of varicosities. And some of these can be quite painful. And this is kind of rare of the vulvar, but you can get vaginal and vulvar varicosities as well. And we'll talk more about that later when we talk about bleeding. Hemorrhoids, very common in pregnancy because of the increase in blood flow. All right, cardiovascular changes in pregnancy, plasma volume goes up 50%. Heart rate goes up 20%. Stroke volume goes up 30%. So heart rate times stroke volume equals cardiac output. So cardiac output goes up 50%. Systemic vascular resistance, however, goes down. So let me tell you what I just told you. The blood pressure drops, the arterial blood pressure, so you don't need to get the ventricles pumping as much because you're going to have easier blood flow. You're going to have an increase in your plasma volume more so than in the increase in red blood cell mass. So we're going to have a decrease in the hemoglobin hematocrit, which leads to a decreased viscosity. So the decreased viscosity enhances the blood flow. On top of that, we have a cardiac output which goes up by 50%. The systemic vascular resistance goes down. So all of these are designed to enhance the uteroplacental fetal blood flow. All of these. Plasma volume goes up. And you can see this is the first trimester, this vertical line over here. Even by the first trimester, it's gone up significantly. What I want you to notice is what is the relationship between the increase in plasma volume and the birth weight of the baby. If the plasma volume increase is less, we have a smaller baby. As we have increase in the plasma volume, we get increased perfusion of the uterus and placenta, and you can see the weight of the baby goes up. It is good, it is important, it is desirable that plasma volume goes up. Now, what finding on physical exam would tell you that she has expanded her blood volume? There's one specific thing that you can look for on physical exam, not edema, not edema. It is listening on the chest. Are you with me? It is a murmur. And what kind of murmur is it? It is a crescendo, decrescendo, mid-systolic flow murmur. That tells me she has expanded her blood volume. I like to hear that. That's important. Here you can see the systemic vascular resistance goes down, meaning arterial pressure goes down, and all of these are to enhance the uteroplacental fetal blood flow. Here we have heart rate goes up 20%. We talked about that. Stroke volume goes up 30%. If you add the heart rate increase and the stroke volume increase, cardiac output goes up 50%. Now what I want you to notice is how quickly does that happen in the pregnancy. This vertical black line is about the end of the first trimester. You can see by the end of the first trimester, we've already got a 40% increase in cardiac output. So if a patient is cardiac jeopardized, she doesn't have good cardiac status, she's going to go under very quickly. If she is doing well, if the patient is doing well after the first trimester, she will probably be able to cruise on through until delivery, because she's going to see a very rapid increase in cardiac output already by the first trimester. Cardiac output varies by maternal position. Here is a pregnant woman laying on her back. This is the uterus. Here's her umbilicus. This is her spinal column. This vessel can get compressed by the uterus. What vessel, what great vessel gets compressed? It is the inferior vena cava. And what's going to happen to the blood flow back to the heart if the vena cava is compressed? It's going to be decreased. So when you have decreased cardiac return, you have decreased cardiac output, and the patient says, I feel like I'm going to faint, because her blood pressure is dropping. So what do? You lay her on her side. Lay her on her side, and best would be on her left side, to avoid supine hypotensive disorder or inferior vena cava syndrome. Hematologic. Red blood cell mass goes up 30%. Plasma volume, we already talked about, goes up 50%. The red blood cell mass goes up, but the plasma volume goes up more, so we're going to get a dilutional effect, which will lead then to a decrease in hemoglobin and hematocrit. Now, when you look at the hemoglobin and hematocrit, it's going to be down compared to what it should be in a non-pregnant woman. But this is not anemia, because she actually has increased her red blood cell mass. This is a dilutional effect only. And the purpose of this is to get a decreased viscosity, so we get an increase in blood flow. White blood count goes up, 10,000 to the upper limits, to 16,000. In labor, it can be 20,000. So white blood count normally can increase without infection. Erythrocyte sedimentation rate also goes up. Let me just tell you this. All plasma proteins go up with exception of albumin. So what is it that causes the ESR to go up? It is because of the increase in gamma globulins and the beta globulins. All of those will go up in pregnancy with the exception of albumin. So SED rate goes up, white count goes up. So let's say you're a general surgeon. The patient comes to you at 14 weeks pregnant and she's got right lower quadrant pain. Your concern appropriately would be, does she have appendicitis? So you're going to look for a white count, you look for a SED rate. White count is 15,000, the SED rate is increased. Does this mean she's got appendicitis? No. So you've got to take into consideration what are the normal physiologic changes in pregnancy, and that can be confusing. You can see the clotting factors also will go up, which increases the risk of DVT and thrombosis. Platelets don't change much. They stay about the same, 100 to 150,000. So plasma volume clearly goes up more than the red blood cell mass, resulting in a decrease in the hemoglobin. Here you can see in the beginning of the pregnancy, the normal hemoglobin is from 12.5 to 14.5 in a woman. Notice at the lowest point, the normal hemoglobin is from 10.5 to 12.5. So what we see is a 2-gram drop in hemoglobin, which is physiologic and normal. Physiologic and normal. Physiologic anemia is not a true anemia. All right, the GI tract. The GI tract, smooth muscle tone, goes down. Bowel motility goes down. So it takes longer for the nutrients to make their way through the intestinal tract. And this is probably because of the smooth muscle relaxation effect of progesterone. That will result then in an increase in emptying time and an increase in residual volume. So when we look at the gastroesophageal sphincter at the junction of the stomach and the esophagus, it's going to relax. and the residual volume in the stomach will go up because there's increase in emptying time. So you can have slopping up of the acid from the stomach into the esophagus, resulting in GERD, namrita. Exactly. The reason for the epigastric pain, most commonly in pregnancy, it's not severe preeclampsia, it is reflux. It is GERD. And that's very, very common. So, results in reflux esophagitis, cholelithiasis, and constipation. And talk about cholelithiasis, look at this. This is amazing, the stones in this gallbladder. All right, the pulmonary changes. Not a whole lot, but there are significant changes. When we look at, and this is in your book, inspiratory reserve volume, the deepest breath you can take in, that is inspiratory reserve volume. That goes down in pregnancy. The residual volume, that is the air trapped in the lungs. It goes down in pregnancy. The extra air that you can blow out, which is called expiratory reserve volume, goes down as well. But notice what happens to the tidal volume. The tidal volume goes up. It is the only one of these four volumes that goes up, tidal volume, and that is the air which is removed. It goes in and out of the lungs with quiet respiration. So if tidal volume goes up and respiratory rate stays the same, which it does, what happens to minute ventilation? Minute ventilation will go up. The air moved in and out of the lungs in 1 minute will go up. Okay, that's just physiological. If the minute ventilation goes up, what will that do to the arterial blood gas PCO2? If you're breathing more air in and out, the PCO2 will go down. Instead of the PCO2 being 40, it will be 25 or 30. And that will make your arterial blood gas pH, instead of 7.4, it will be a 7.5 perhaps. So you have a respiratory alkalosis. A respiratory alkalosis. It looks very similar to the early changes of asthma. Increase in ventilation, decrease in PCO2, and increase in pH. So when we look at the blood gases, we need to interpret it keeping in mind the normal change of pregnancy. When the arterial blood gas pH goes up, what happens to the urine pH? The body will try to compensate by kicking out into the urine the bicarbonate, which will cause the urine pH to go up. If the urine pH is not acidic, it increases the risk of urinary tract infections. And that's one of many reasons why there's more UTIs in pregnancy. So you can see that the increase in tidal volume can have a lot of changes on the physiology of the pregnant woman. The kidneys. Because of the increase in cardiac output, there is increase in renal plasma flow. When there's an increase in blood flow to the kidneys actually increase in size. They will hypertrophy in pregnancy. Now, the smooth muscle in the renal pelvis will relax, and so the renal pelvis will increase in size. We will have a physiological pyelectasis. The ureters will also dilate because of the smooth muscle relaxing effect of progesterone, so we will have a hydroureter. Let me show you a picture of what that looks like. This is a kidney on the left side. This is a normal renal pelvis and the normal ureter coming down here. But look at with this kidney here. Look at the size of this renal pelvis. Hydronephrosis, pyelectasis, whatever you want to call it. But this is because of the smooth muscle relaxing effect of progesterone. And notice how the ureter is increased in size as well. The normal size of a ureter should be a pencil like this. But the actual size is like your thumb. So it's a big increase. Now, when you increase the diameter of a vessel where fluid is running through it, what will happen to the velocity of the flow through a hollow structure which is dilating. It will slow down. This is what we call stasis. And when you get stasis of urine, that also increases the risk of an infection. So when we think of a pyelonephritis in pregnancy, which we'll talk about probably after I come back from Finland or Norway, there is increased pyelonephritis in pregnancy. And which side is it going to be more? It'll be on the right side, because the dilation of the ureter and the renal pelvis is 90% of the time on the right side. It does return to normal after pregnancy. It does. Renal function. Because of the increase in blood flow through the kidneys, we're going to have an increase in efficiency of what the kidneys are doing in removing the wastes. Therefore, the actual measures of the waste in the bloodstream will go down. The efficiency parameters will go up. Renal plasma flow goes up. Glomerular filtration rate goes up. Creatinine clearance goes up, which then results in a lowering of BUN. Instead of 8 to 10, it should be 5 to 6. Creatinine, instead of being 0.8 to 1.2, should be 0.5 to 0.6. Oops. Uric acid, instead of being 7 to 10, should be more like 4 or 5. So the normal changes of pregnancy will increase the evidences of renal efficiency, and it will decrease the waste products that we measure in the electrolytes. The question Diamond asks, why is it more on the right than the left? There's been all kinds of hypotheses. I do not have any good answer. I don't think anybody really knows. Glucose will normally go up in the urine, but does the glucose go up in the bloodstream? It does. We'll talk about that more later. But we don't use glucosuria to make a diagnosis of diabetes. We need to measure the blood glucose. Now, protein in the urine stays about the same. It doesn't significantly go up, and we'll talk more about that later. If you have more than 300 milligrams in a 24-hour urine protein, you have significant proteinuria. Endocrine changes, the pituitary gland will increase in size, and that's because of the increase in blood flow. If we get hypotension in a pregnant woman, it could result in ischemia of the anterior pituitary. If we have ischemic changes which result in hormone deficiencies, we can have Sheehan syndrome, and this is seen most commonly in postpartum hemorrhage. Postpartum hemorrhage. This is the anterior pituitary here. You can see the tropic hormones that it makes. Prolactin, FSH, follicle-stimulating hormone, luteinizing hormone, adrenocorticotropic hormone, and TSH. Now, if we get infarction of the anterior pituitary, but it's mild, it will usually show up as a decrease in prolactin. This clinically results in failure for engorgement to occur. If we have more infarction, we will get the gonadotropins, and so FSH and LH will not be made. And that is interesting, because that leads to what clinical finding? What is the clinical finding when FSH and LH go down? It is amenorrhea, and this will be secondary amenorrhea. One of the causes of secondary amenorrhea is infarction of the anterior pituitary. And if the complete anterior pituitary is gone, you'll get hypothyroid, and you will get Addison's disease. So these are all good board questions. Good board questions. Thyroid gland. The thyroid gland in pregnancy increases in size because of the increase in blood flow. Total T3 and total T4 will go up because TBG, or thyroid binding globulin, goes up. But is it the total T3 and total T4 which is important physiologically, or is it the free T3, free T4 which is important? And it is a free. Therefore, when we look at TSH, there is no significant change in the hypo and hyperthyroidism values that we use in pregnancy. Free T3 and free T4 do not change from the normal values, and the free thyroxine index will balance things out. So TSH and free T3, free T4 do not change. Okay, a few words about the fetal circulation. How many vessels are there in the umbilical cord? 1, 2, or 3? Answer is 3. There are 2 umbilical arteries. There is 1 umbilical vein. The oxygen saturation is highest in which of those vessels, the vein or the artery? And the answer is the vein. And this is opposite to what you'd expect after birth. The vein usually has a lower oxygen saturation, but not in the umbilical circulation. There are 3 shunts, which we will talk about. The DB is the ductus venosus. The FO is the foramen ovale. The DA is the ductus arteriosus, and I'll show you a picture of that as well. Also, fetal hemoglobin, which is hemoglobin F, has a higher affinity for oxygen, so it will shift the oxygen hemoglobin dissociation curve to the left. I'll show you that later. This is a photo that I took of a segment of umbilical cord. You can see the red is pointing to a big, plump, single vessel. The blue is pointing to 2 smaller vessels. The red is pointing to artery or vein. The red is pointing to the vein, absolutely. And the blue is pointing to the arteries. The placenta sends blood to the fetus through the umbilical vein. The umbilical arteries carry blood from the fetus to the placenta. Now, here I took some blood gases and aspirated blood. This is a more reddish, this is more darker. Is this top one arterial or venous blood? It is venous blood. You guys got it. Right. The venous blood in the umbilical cord is the highest oxygen. The ductus venosus carries blood from the umbilical vein to the inferior vena cava. This is in your notes. The foramen ovale takes blood from the right atrium and dumps it into the left atrium, so it doesn't need to go through the pulmonary circulation. And the ductus arteriosus takes blood from the pulmonary artery and puts it through a detour called the ductus arteriosus, so it doesn't need to go to the aorta. So the ductus arteriosus takes blood from the pulmonary artery and puts it directly into the aorta. All right, let's look at the placenta here, the anterior abdominal wall of the fetus here, and let's look at the circulation. The umbilical vein is this big vessel that carries blood from the placenta to the fetus. There's only one of those. There are 2 umbilical arteries. They carry blood from the fetus to the placenta. There are 3 shunts. The first shunt is here. Here is the inferior vena cava. Here is the aorta. This is the umbilical vein. And the blood comes from the umbilical vein into the inferior vena cava through the ductus venosus. This is the foramen ovale. It takes blood from the inferior vena cava that comes into the right atrium, and instead of going through the right ventricle and the pulmonary artery, it goes from the right atrium into the left atrium, in the ventricle, and out the aorta. The ductus arteriosus takes blood from the pulmonary artery and diverts it to the aorta so it doesn't have to go out into the lungs, because the lungs aren't functioning to aerate the air in utero. This is looking at the oxygen hemoglobin dissociation curve of the fetus compared to the mother. This is PO2 on the x-axis. This is oxygen concentration on the vertical axis. And what you can see, fetus hemoglobin F is the blue curve, and the reddish curve is the mom. At a PO2 of 30, the oxygen content of the maternal blood is only half of what the fetus is. The fetus does well, no problem, with a low PO2. I talk about it this way. The fetus lives on the top of Mount Everest, or in California on the top of Mount Whitney. That's the highest peak in California. Low PO2, but that doesn't problem for the fetus because it has the hemoglobin F. But once the baby is born, it will start to replace its hemoglobin F with hemoglobin A, and that's going to be what results in the physiologic jaundice because of the breakdown of the red blood cells after delivery. All right, just a few words about lactation. Is breastfeeding a good thing or not a good thing? What do you think? It's a good thing. It is a great thing. It is excellent. Yes. And notice this baby has eye contact with mom. Very good. All right. The breast anatomy. The lobes of the breast are composed of alveoli. The alveoli are what make the milk. The ducts take the milk from the alveoli and will move it to the nipples where the baby has access to it. The size, the shape of the breasts is determined by the adiposity and the fat. A woman who has large breasts has more fat. A woman who has small breasts has less fat. But the milk-producing apparatus is the same. And the ligaments will maintain the shape. As time goes on, with aging, you get drooping of all structures, including the breast. In terms of hormones on the breast, estrogen at puberty stimulates the ducts, the nipples, and the fat. And this is the first evidence of puberty is thelarchy, or breast development. Progesterone, instead of working on the ducts, works on the lobules and the alveoli. And this is seen on the non-pregnant woman. In the first half of the cycle, where estrogen is dominant, we have the main impact on the ducts and the nipples. In the last part of the pregnancy, of the menstrual cycle, when the progesterone is elevated, we have the stimulation of the lobules and the alveoli. And so the breasts are actually a little bit larger. So if you're going to do an X-ray and a mammogram, do you want to do it in the first half of the cycle or the second half of the cycle? You want to do it in the first half of the cycle because the breasts are less dense at that time. Prolactin is important to stimulate the milk production. We talked about this. If you have Sheehan syndrome, prolactin isn't around, you're not going to get engorgement of the breasts. And oxytocin is what is released from the posterior pituitary when the fetus, not the fetus, when the newborn, the neonate, is sucking on the breast. It will stimulate a reflex arc which releases oxytocin. The oxytocin comes down and it contracts the myoepithelial cells which are surrounding the alveoli and squirts the milk out of the alveoli into the ducts and makes it accessible for the fetus. Okay, we come to the end of our first hour. Let's take a 10-minute potty break, and I will see you in 10 minutes. I'll be right back. Yes, Maggie, if we could continue on. Yeah, this is good. All right. Okay, now we move to embryology and fetology. The first thing you need to know is that physicians generally, they measure the length of a pregnancy. Oh, can't see me. Sorry I deprived you of my beautiful face. Physicians talk about the length of pregnancy by the menstrual weeks. Embryologists talk about pregnancy as conceptional weeks. And so here we're going to look at post-conceptional weeks rather than menstrual weeks, because the menstrual weeks can vary depending on the length of the cycle, but conceptional weeks are always the same. So we will look at 1, 2, 3, 4 to 8, and so on. All right, let's look at your handout, and this will look at week 1, week 2, week 3, week 4 to 8. Now, I've put in parentheses here, this is menstrual weeks, 3, 4, 5, and 6 to 10. Do you see that? The difference is you add 2 weeks to the conceptional weeks to make the average menstrual weeks, because there's 2 weeks between the conception and the beginning of the last menstrual period. And so that's where we get the 2 weeks. Okay, the first post-conceptional week starts with conception, ends with implantation on the endometrial surface. In the first half of the first week, the dominant structure is the morula. In the second half of the first week, the dominant structure is the blastula. If we have twins which occur at the morula stage, they will be dichorionic diamnionic twins. If we have splitting which occurs at the blastula stage, they will be monochorionic diamnionic. We will talk more about that later. There are no malformations in the first week because there are not the 3 germ layers. You cannot have a true malformation until you have the 3 germ layers which are present, the ectoderm, endoderm, and mesoderm. Okay, the second week begins where the first one leaves off at implantation. It ends with a 2-layer embryo. I'll show you pictures of all this. What we're looking at here is the bilaminar germ disc, the 2 layers, which is the epiblast and the hypoblast. If there is splitting which occurs in the first half of the second week, it will be monochorionic, monoamniotic twins. If it is an attempt to separate, but they don't successfully separate, it will be conjoined. No malformations because there's no 3 germ layers. It is only in the third week, at the end of the third week, that we have the 3 germ layers. We begin with a 2-layer embryo, we end with a 3-layer embryo, what I call the trilaminar germ disc, ectoderm, mesoderm, and endoderm. No twinning occurs here. Malformations are possible at the end of the third week. And from the 4th to the 8th week, this is the period of the formation of all the different organs. We go from a 3-layer embryo to a fetus. At the end of post-conceptional week 8, at the end of post-menstrual week 10, all of the major organs are already formed, and it's just a matter of increasing the size of them. There is no significant malformations after week 8, after week 10. But during week 4 to 8 or 6 to 10, that's the biggie. Okay, we'll go over that all in just a minute. So week 1 begins with ovulation, ends with implantation. It starts with ovulation and conception, and here we have the largest cell in the human body, the egg, which is being approached by the smallest cells in the human body, the sperm. All right, the first post-conceptional week starts with fertilization or ovulation, and you notice that fertilization can occur within 12 to 24 hours of ovulation. The egg is only fertilizable for the first 12 to 24 hours. The first week ends with implantation, but the first week can be divided into two phases: the intratubal phase, the intrauterine phase. The intratubal phase, the zygote becomes a morula. On the intrauterine phase, the morula becomes the blastula. It goes into the uterine cavity, and there it implants. So here we have the fertilization, here we have the 2-cell embryo, here we have maybe 16 cells. This is a morula. Each one of these cells can become a separate individual. None of these have yet differentiated. But by the time we move from a morula here to a blastula, the chorion has already differentiated, and that is the outer layer of cells. These will become the placenta. It is the inner cell mass which is capable of splitting. So, let me just come back here. Here we have the tube. Here we have the ovary. Ovulation occurs. Here's the egg. The egg is picked up by the fimbria, moved into the tube. It is in the distal tube that the conception takes place right here. And then we have the zygote. The zygote will change from a 1-cell to a 2-cell, a 2-cell into a 4-cell, 4-cell into an 8-cell, and so on. And here we have the morula, the intratubal phase. The morula then enters into the uterine cavity, becomes a blastula, and you can see inner cell mass here, outer cell mass, or the chorion there. Here's a better picture. The blue is the embryo. That's what will become the embryo. The brown will become the placenta. And here you can see the implantation occurring on the endometrial surface. The trophoblastic cells are invading. This is the end of the first week. Week 2 begins with the implantation and ends with the 2-layer embryo. This is the formation of the bilaminar germ disc. Here we have the bilaminar germ disc. Epiblast in blue, hypoblast, which is down here. I already showed you this picture. This is the end of the second week, day 12. Day 14 would be the end of the second week. And that's when you have the 2-layer embryo, and we have the syncytial trophoblast invading. All right, here's the 2-layer embryo. This is the epiblast in blue, hypoblast is in yellow. Down on this end of the embryo, we have the primitive streak. And what happens here, these epiblast cells move toward the primitive streak. They go down through this and form a layer between the epiblast and the hypoblast, which will become the mesoderm. That is the 3-layer or trilaminar germ disc. Here is the primitive streak. Here are the epiblast cells moving in here. They come on down between, and they will be forming the 3rd layer. You've got to have the 3 germ layers before you can have any teratogenesis. Here we have what will become the ectoderm, here we have what will become the mesoderm, and here we have what will become the endoderm. This is a rat embryo, ectoderm, mesoderm, endoderm. All right, the 3 layers have been formed. Now we have the formation of the major organ systems. The first one which will form is the central nervous system. The second one will be the cardiovascular system. Those are the 2 earliest ones. And that's weeks 4 to 8. Those are the weeks with the maximum risk of teratogenesis. The morula becomes a blastula, post-conception week 1. The post-conception week 2 is when we have the bilaminar germ disk. The trilaminar germ disk, post-conception week 3. And then we have the post-conception week 4 to 8, 3 germ layers of differentiating, the greatest risk of malformations. And we'll talk more about this later. Folic acid can prevent neural tube defects. All right, embryology of the female reproductive tract. Obviously, we are talking about the female reproductive tract for the next 8 evenings when I will be lecturing to you. The internal genitalia of the reproductive tract arise from the paramesonephric or the Müllerian duct. Here we go. The mesonephric duct will become the kidney. The paramesonephric duct will become the uterus and the tubes. The reason I point this out to you, if there's an anomaly in the one, look for anomalies in the other. If there's a bicornuate uterus, look for a renal abnormality. If there's a renal abnormality in a female, look for a Müllerian abnormality. All right, what are the derivatives of the Müllerian duct? The fimbria, or the distal end of the tubes, which pick up the egg. The oviducts, which move the egg down to the uterine cavity. The uterine corpus. The corpus is the body of the uterus. The cervix of the uterus is here, and the proximal vagina. These arise from the Müllerian duct. If we have Müllerian agenesis, what is missing? There's no problem with the ovaries. The problems will be in the fimbria, in the oviducts, in the corpus of the uterus, in the cervix of the uterus, and the proximal vagina. That is Müllerian agenesis. We'll talk about that in a few weeks. Now, both male and female have in their early embryonic life both Wolffian and Müllerian ducts. In a male, the Müllerian will disappear. In a female, the Wolffian will disappear. What makes those appear or disappear? And this is in your book. In a female, what hormone is needed for external genital development? Nothing. In a female, what is necessary for the Müllerian duct to develop? Nothing. In a male, what is necessary for the external genitalia to develop? Penis and scrotum. Androgens, and specifically dihydrotestosterone. The internal, which is the Wolffian duct, in order for it to develop, it needs androgens. So notice the default differentiation is in the female direction unless something comes along and stimulates us in the other direction, and that's what happens in the male. The default differentiation is in a female direction. Okay, Maggie, if we can go to second part or B. All right. Thank you, Maggie. All right, teratology. We've already talked about the stages of teratogenesis, but let's just review those once again. The effect of a teratogen, let's say it is a medication, let's say it is radiation, let's say it is heat or whatever, hypothermia. If there is exposure of the embryo to a teratogen before the end of week 2, there will be either survival intact or it will die. There will be no malformations because we don't have the 3 germ layers. It is only at the end of week 3 until the end of week 8 that the greatest risk of teratogenic injury. After week 9 and on, it's minimal risk. So let's say, for instance, we have a patient who has leukemia who was diagnosed at 7 weeks post-conception. And we want to give her chemotherapy. Is there any risks? Yes, huge risks. But let's say she is 11 weeks. Very different, because by that time, the embryogenesis is already complete. All right, here is our first case. A 36-year-old woman underwent a barium enema for rectal bleeding on February 1 with estimated radiation dose of 4 rads. Her last menstrual period was January 1. She has 35-day cycles. She was not using any contraception. A urine pregnancy test was positive on March 15. She inquires regarding the risk to her fetus of teratogenic injury. All right, let's dissect this and see what happens. All right, her last menstrual period was January 1. She has 35-day cycles. What day in January did she ovulate? What day of January did she conceive? If she was on a 28-day cycle, she would have ovulation and conception on day 14. But because she has a 35-day cycle, you're very correct, Anna Maria, it is going to be on day 21. So January 21 is when ovulation occurred. The barium enema was February 1. How many days post-conception would that be? That would be around 10. What week post-conception is that? That will be the second post-conceptional week. Is there any risk to her fetus? None. You can with confidence say there is no teratogenic risk to this fetus. Are you with me on that? Because until you have the end of the 3rd week, you're not going to have any risk. It will either be death or it will be survival intact. All right? So the only risk is going to be of teratogenesis from the end of the 3rd week until the end of the 8th post-conceptional week. In between there's no risk because you don't have the 3 germ layers. You don't have the 3 germ layers. Okay, even if we look at the radiation dose, less than 5 rads, no anomalies reported. From 5 to 10, it's low. The primary risk would be if it's over 10. And when you look at any of the diagnostic radiological procedures that we do, almost none of them will exceed 10. So either it will be normal or it will die, but we will not have any anomalies. Okay, I want to just briefly go over the categories of drugs by the FDA for pregnancy. We can have category A, B, C, D, and X. And A is never a problem. It is known to be safe in animals and humans. B, no evidence of risk in animals, but human study has not been done. Category C, risk cannot be ruled out. Risk is present in animals, but we don't have good study in humans. Most of the drugs we use are category B and C. D is positive evidence of risk. We know that there is fetal risk, but the benefits of the drug may outweigh the risk, and that is when you use, for instance, the anticonvulsants. Category X should never be used any time in any pregnancy. There is no benefit which outweighs the risk. I have given you in your notes very specific syndromes that can occur with drugs. But I want to show you some pictures first. Fetal alcohol syndrome, FAS. This is the most common preventable cause of mental retardation. And I want you to notice the long philtrum, the space between the nose and the upper lip. And notice it's flat. Now there's lots of other findings with fetal alcohol syndrome that I will let the pediatricians talk to you about. DES is diethylstilbestrol. This was a non-steroidal estrogen which was used to try to prevent miscarriages. What we normally have is a triangular-shaped uterine cavity, but with DES exposure we can have a T-shaped uterus. That's a good board question. But what is the worst thing that could happen in a female reproductive tract who was exposed to DES? And that is clear cell carcinoma of the vagina. That is very rare, but that would be the worst thing that could happen. The anticonvulsant dilantin phenytoin can have craniofacial dysmorphism. But if you would remember for the exam, nail hypoplasia. See how small these nails are? There's no functional limitation because of this, but it's a good board question. Nail hypoplasia. Isotretinoin, the trade name is Accutane. Not a good drug to use in pregnancy. It is used for acne. It is topically safe, but it is systemically not good. There's lots of things that can happen. They're all listed in your book. There's cardiac anomalies, but there is also the small ears. And here you can see the ear malformation. And this over here is a cochlear implant with isotretinoin. Notice the mal-shaped ears here. Did it work? What is the most common reason why first trimester losses occur? It's because of chromosomal anomalies. And you're not going to change that anyway, so it did not work. But that was something that was prescribed, if you can believe it. Epstein anomaly. This is the right atrium of a normal heart. Look at the atrium of this heart. Look at how huge it is. And notice what has happened to the tricuspid valve. Downward displacement of the tricuspid valve. This is associated with lithium, Epstein anomaly, good to remember. Normal, enlarged, Epstein anomaly, the right atrium. Thalidomide is associated with phocomelia. Phocomelia is limb reduction defects. This is a medication that was given to prevent nausea and vomiting in pregnancy. It worked quite well, but between days 42 to 48, when the limb buds were developing, it prevented the development, and you can see you've got here the limb reduction which occurs. It was not allowed in the United States, and so we didn't see it here, but in Europe, many women and babies were exposed. Thalidomide is now used in treatment of leprosy. And Brazil has a lot of leprosy in the world. This is interesting when I look at what we used to say to our patients about other things. This is advertisements. More doctors smoke Camel cigarettes than any other cigarette. What's the implication here? If your doctor smokes, then you should smoke too. And now we know that a third of the people who smoke are going to die from their disease. Absolutely crazy. And yet, that is what we used to advertise. It makes me wonder what 25, 10 years from now we will say about things that we're saying today. Look at this. For a better start in life, start cola or 7-Up. Can you believe it? Crazy. We've got to realize that knowledge is fleeting and that what was true yesterday may not be true today, at least scientifically. Okay, deciduous teeth discoloration, that's tetracycline. Valproic acid or Depakote associated with neural tube defects, and that's mostly spina bifida. It also causes congenital heart disease. So valproic acid, neural tube defects, congenital heart defects. Now, obviously, this is going to be early in the pregnancy because that's when the neural tube defects develop and the cardiac malformations. Coumadin is associated with chondrodysplasia punctata and optic atrophy. Okay, in your book, I'm not going to go over these terminology for perinatal statistics. I'm not going to go over this for perinatal losses. But I want to go through this figure right here. Because I want to talk about what is it that constitutes an abortion, what constitutes a fetal death. Now here we can see is conception, is the last menstrual period, right here. Ovulation occurs and conception occurs 2 weeks after. So that's right here. So technically, as far as the state statistics are concerned, if there is loss of a pregnancy between conception and 20 weeks, which is right here, it is called an abortion. Whether it's live or dead, whether it's 1 or 3 or 5 embryos, it doesn't matter. If it is a loss which occurs before 20 weeks, it's considered an abortion. If there is a loss of a pregnancy between 20 weeks and 40 weeks, which is term, that's at delivery, that's a fetal death. And now you have to issue a certificate for fetal death. If you have let's say, a preterm baby that is born at 18 weeks, that's not considered a fetus. It's only after 20 weeks. if there is a death which occurs between birth and the first month of life, which is right here, that's called a neonatal death. And if we put together the fetal deaths and neonatal deaths, they will make the perinatal death. So perinatal death is the fetal and neonatal deaths added together. And then infant deaths is any deaths which occur in the first year after birth. Okay, so one of the definitions for an abortion is loss of a pregnancy between conception and 20 weeks. These are the state statistics. And the fetal death will be anything after 20 weeks. However, medically, embryologically, what I just explained to you was that the embryonic period is from conception to 10 weeks. After 10 weeks, all the organ systems are developed, and now we have a fetus. So this is a medical definition. This is a state public health definition. They're both correct, but you need to understand the context that when we talk about a 16-week fetal demise, we are correct medically because the transition from embryo to fetus occurs at 10 weeks. But from state statistics, we don't issue a certificate of fetal death until 20 weeks. Are you with me on that? There's two different frameworks for looking at what is a fetus and what is a fetal death. Okay, let's look at genetic disorders. The indications for genetic counseling. A 37-year-old gravida 5 para 0 AB4 woman comes for prenatal care at 7 weeks gestation. She's experienced 4 previous spontaneous first trimester abortions. She's concerned regarding the likelihood of her next pregnancy being successful. First, let me just look at G5. The G stands for gravida, the number of confirmed pregnancies. The number of confirmed pregnancies. By the way, if you miss something what I'm saying, Dr. France is our TA who is available if you need to get further clarification while I'm moving ahead. Okay, so Dr. France, I want to give you some business, but hopefully we'll keep that to a minimum. So G5 is a number of confirmed pregnancies. P is the number of pregnancies that went to 20 weeks or more, and AB is a number of pregnancies that ended before 20 weeks. So that's gravida, para, and abortus. So she's 37. She's lost 4 first trimester pregnancies. Is she going to lose another one? I can understand why she should be concerned and anxious. When we look with the likelihood of a pregnancy loss, the most common reason is genetics. And the genetic risk goes up with maternal age. And here you can see maternal age 20, 25, 30. You can see it goes up and up and up. And the total risk of any aneuploidy is listed in this column here. So the ideal optimal age for childbearing is between 20 and 24. That biologically is the truth. And ladies, I'm sorry, this is just the way the data comes. Now, even at age 49, the risk of having an abnormal baby is 1 out of 7. So 6 out of 7, you're going to be a winner. Everything will be okay. But it is significantly higher than it was when you were 20. And you can see here, at age 35, the risk of an aneuploidy is about the risk of losing a pregnancy from amniocentesis. So then we say we will offer amnio at 35 or greater if she would like to. Having said that, we do have a non-invasive prenatal testing that I will talk about before the evening is over. The most common indication for genetic counseling is AMA. That is not American Medical Association, it is advanced maternal age. Now you can have genetic counseling because of a previous child that has some death or disorder, pregnancy or fetal losses, positive family history of genetic diseases, abnormal prenatal diagnostic tests, blah, 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 blah. But the main one is AMA, no question. What is AMA? Now, this woman is clearly over 50. But AMA is age 35 at the time of delivery or older. That is AMA. Now, there's a couple who came to see me. When I saw her and I saw him, I said, this must be her father or maybe her grandfather. But it turns out he actually was the father of the baby. Now, when you have advanced paternal age, you have more mutations which occur. But when you have advanced maternal age, not paternal, but maternal age, it is increased risk of aneuploidy, gross chromosomal disorders. This is a woman who, age 61, gave birth to her own granddaughter. That's interesting. This woman's daughter had Müllerian agenesis, did not have a uterus. She had ovaries, so she could have genetic babies of her own, but she couldn't carry them because she had no uterus. So this woman became her daughter's surrogate mom, and she was carrying her own granddaughter. Can you believe that? Amazing. The oldest mother ever documented is this age 66-year-old woman, a Spanish woman, who had IVF twins. Unfortunately, 2 years later, she was dead from ovarian cancer. Now, this is a woman who is from India. Age was not confirmed, but had daughters, but didn't have any son, so ended up spending lots of money getting in vitro fertilization and has these twins, and now she's happy. Would you be happy at age 70 with twins? Mamma mia. All right, chromosomal aberrations. Here's some genetic terms you need to know. These are in your book, in your notes. Aneuploidy is a garbage term, any abnormality. It may be too many chromosomes, it may be not enough, it may be rearranged. But it's anything other than normal. That's aneuploidy. Polyploidy is where you have more than 2 sets of chromosomes. So you could have triploidy or quadruploidy, 4 sets. Mosaicism is where you have more than 1 cell line in the same individual. I'll show you a picture. Trisomy is an extra single chromosome, not an extra set. And monosomy is when you have a missing chromosome, a missing single chromosome. All right, this is not in your notes, but you need to see this at least. If you were presented with a karyotype on the exam, what would you look for? Karyotypes have 4 rows of chromosomes. The large chromosomes, these are large autosomes, and the medium autosomes. You're very seldom going to see any abnormality here, because if you have a loss or addition of these large chromosomes, you have very early embryo death, and you never see a fetus. It's going to be in the smaller chromosomes, either the 3rd row or the 4th row, and the sex chromosomes, which are down here. The most common aneuploidies that we see are trisomy 13, trisomy 18, trisomy 21, and the sex chromosome, which we will talk about in just a minute. So don't pay too much attention with these large autosomes, because you're very seldom going to find one. Now here you can see we have 3 number 1, 3 number 2, 3 number 3. This is called triploidy. 3 sets of everything. The most common is a 69XXY, and this is associated with an incomplete molar pregnancy. Incomplete molar pregnancy. We have dispermic fertilization. Normally, the zona pellucida undergoes chemical changes, which makes it impenetrable to a second sperm. But in this case, we have 2 sperm that penetrate, and we have 3 pronuclei rather than 2. And this is a fetal death with a triploidy baby, 69XXY. Mosaicism. This is a normal woman who has every cell in her body at 46XX. This is a patient who has mosaics. Half of her chromosomes are normal, but half of them are abnormal. In this case, this is Turner's. So this is called a Turner's mosaic, 45X/45 or 46XX. Varying different kinds of mosaicism, many different cell lines. Now, what is the problem with mosaicism? Multiple cytogenetic cell lines. If you have premature ovarian failure, one of the causes may be mosaicism. So let's say you have a woman who undergoes menopause at age 28, 30. You better check to see her chromosomes. The other possibility is you can get cancer of the ovary, a gonadoblastoma of the ovary, if you have mosaicism. So these would be two board questions that you should remember. All right, common aneuploidies, trisomy, extra single chromosome. The most common one is 47XX+21. This is genetic shorthand for a Down syndrome female. The most common monosomy, which is a single missing chromosome, is 45X, which is gonadal dysgenesis or Turner syndrome. The most common polyploidy or extra set of chromosomes is 69XXY, and that is with an incomplete molar pregnancy, and we'll talk more about that later. All right, Turner is 45X, Klinefelter 47XXY, Down trisomy 21, Edwards trisomy 18, Patau is trisomy 13. The most common seen at term is trisomy 21. And the reason for that is that trisomy 18 and trisomy 13 are so severe in their effects that you have a fetal death which occurs and the pregnancy doesn't go to term. So the Down, the trisomy 21, is the least severe. At conception, the most common one that we see is trisomy 16 and Turner syndrome. 98% of Turner syndrome pregnancies are spontaneously aborted, so only 2% survive. Turner syndrome, 45X, 1 in 2,000 deliveries, primary amenorrhea, web neck, streak gonads. That is Turner syndrome. Here you can see is the first, second, third row of chromosomes all look good. The small ones down here, but notice there's only one X. Only one X. Right there. This is loss of the paternal X chromosome. That would be a good board question. Loss of the paternal X chromosome is Turner syndrome. Here we have the woman. She is 17, but her body looks like she's 10. Prepubertal, because she doesn't have estrogens. Her height, 1 foot, 2 foot, 3 foot, 4 foot, 6 or 7. So short stature. And the reason she has no secondary sex characteristics is because she has no ovaries or no follicles in her ovaries. You can see the vertebral body right over here. And this is a cystic hygroma, which you see in some of those pregnancy losses which occur with Down syndrome or Turner syndrome. The neck here, the web-shaped neck, occurs if you have a survival of a cystic hygroma and collapsing of that loose skin. This is a fetus that didn't survive, and you can see how huge the cystic hygroma is. You can see there is a fluid which is accumulated all around the body. This is what we call fetal hydrops, and this would be a non-immune hydrops. One of the causes of non-immune hydrops is aneuploidy. Good example. Turner syndrome has coarctation of the aorta, most common, more common, about 1%. You can see right here is a narrowing of the postductal coarc. Here we see the streak gonads. This is the round ligament. This is the fallopian tube, and this is the utero-ovarian ligament. But there really is no ovary. There is just fibrous tissue. And so there's no follicles to respond to the FSH, No estrogen is produced. So what is the level of the FSH? Very, very high. Very high. Klinefelter syndrome, 1 in 1,000, 47XXY. Testicular atrophy, gynecomastia, azoospermia, no sperm. This is sometimes picked up on an infertility evaluation when you do a semen analysis. XXY, double X. XXY, 2 X's and a Y. Now, this is not short stature, which is interesting because trisomy 13, trisomy 18, trisomy 21, Turner syndrome are all short stature. This is normal height, if not a little taller. But notice the obesity of the abdomen. Notice the small genitals, the micropenis, the small scrotum. Down syndrome, 1 in 800, trisomy 21, short stature, mental retardation, endocardial cushion defects. That would be one to remember for the exam. Here you can see 3 of the 21st chromosome, right here. When you look at the rate of Down syndrome by maternal age, age-specific, you can see that the lowest risk of Down syndrome, that's maternal age-specific, is 20 to 24. There's a little bit higher with younger, and then after age 24, you can see it goes up, hop, up, up, and up. So age-specific wise, but when you look at the birth rate per 1,000, and which has the Down syndrome, can you see this green line shows that the highest Down syndrome occurs to moms between 20, this should be not 59, should be 29. Should be women in their 20s. And the reason for this is there are more children born to women who are between the ages of 20 and 30, not because they have a higher rate of Down syndrome. The point here is when you do the screening testing, genetic screening, you've got to offer it to all women, not only women who are over age 35, because the majority of Down syndrome is born to women who are less than age 35. And we already talked about this. The risk of Down syndrome increases with advancing maternal age. Would you remember endocardial cushion defects and duodenal atresia? These are associated with Down syndrome. Would be great board question. Let's look at some of these. This is the heart. This is the right side of the heart, which is blue, the left side of the heart, which is red. This is the interventricular septum. When you have an endocardial cushion defect or atrioventricular canal defect, here's what happens to the interventricular septum. It's gone. Boom, gone. Let's make it go again. Now what do you see? What you see is basically a single chamber, a huge common ventricle. That is the AV canal defect. And 50% of Down syndrome will have AV canal defects. This is a duodenal atresia. Here we have one bubble. Here we have a double. This is called double bubble. Now, when you see an ultrasound dark, black, what is that? The black on ultrasound is there because it is not air, because of liquid. Exactly. So in the uterus, what would this liquid be? What kind of liquid would it be? It would be amniotic fluid. So with duodenal atresia, we would expect extra amniotic fluid. The medical term for extra amniotic fluid is polyhydramnios. Polyhydramnios. Any upper GI obstruction in the fetus can lead to polyhydramnios because the baby can't swallow the fluid which it needs to do. A third of cases of duodenal atresia are trisomy 21. And the two bubbles is the dilated stomach and the dilated proximal duodenum. So, Down syndrome, duodenal atresia, endocardial cushion defect. Edwards syndrome, trisomy 18. Notice mean survival is only 14 days. Most of these babies will die within a few weeks of delivery. Here's trisomy 18, 18 chromosomes. Again here, 18, trisomy 18. Risk factor AMA, the same as for trisomy 21. Do you see this, what we call rocker bottom foot? That is something which has been associated 70% of trisomy 18. Now this is a fetal demise. This is not a normal skin. But this is an abnormal foot. The other thing is the abnormal fist. So we have abnormal foot, abnormal fist. You can see this fist is like this. When I'm doing an ultrasound, and I'm maternal fetal medicine, so I do a lot of ultrasounds, if I see the fetus doing this, I like it. Because it tells me that this is, now if it doesn't guarantee it's normal, but when it's always like this, the clenched fist, I don't like that. Trisomy 18. Now, trisomy 13, mean survival is only 2 days. So this is even worse. Profound mental retardation, very poor survival. Here's the 313 chromosomes. Here's the 313 chromosomes right over here. And this is risk factor advanced maternal age. Severe bilateral cleft lip and palate. You can have an isolated finding of cleft lip and palate, but if it is severe and bilateral, you should think of a trisomy 13. A single eye, which is called a cyclops, a protruding soft tissue above the eye called a proboscis. Think of trisomy 13. Holoprosencephaly. Look at this huge fluid collection in the brain. Look at how attenuated the cortical tissue is. This baby was in a hospice situation, just comfort care, because it wasn't going to survive. Look at the bilateral severe cleft lip and palate. Look at the hypotonia of the hands. Not good. Okay, let's go through the handout real quickly. This is in the book, but this actually is what I want you to see. Okay, Klinefelter's 47XXY, tall stature. IQ may be somewhat low, but it isn't in the range of mental retardation. We talked about microgenitals, small penis, small scrotum, and infertility. Turner syndrome, short stature, and notice all of these are short stature. Turner's, Downs, Edwards, and Patel. Turner's, however, has normal IQ. Web neck, coarctation of the aorta, we talked about that. Down syndrome, trisomy 21, short stature. Some can be functional mental retardation, but duodenal atresia, atrioventricular canal defect. Edwards syndrome, short stature, more severe mental retardation, mean survival 14 days, abnormal feet and fist. Right? We talked about that. And Patel syndrome, trisomy 13, profound mental retardation. Most don't survive over 2 days. Holoprosencephaly and cyclops. Okay, why don't we stop here? Let's take our second break. We're in the middle of the evening, and AMA is age 35 or greater. See you 10 minutes. Okay, here we are back again for our third hour, and we will now move from gross chromosomal abnormalities to single gene abnormalities. The single chromosome abnormalities are what we have with the Downs, with the Turners, with the Klinefelters, and so on. It is the whole chromosome. But when we look at Mendelian disorders, it is not the whole chromosome, it is only a gene on the chromosome. This is Gregor Mendel, who was an Austrian monk who first discovered the laws of genetics, which are now named after him. Mendelian genetics. And here's our case. A 23-year-old black primer gravida is 12 weeks gestation. She's been diagnosed with sickle cell trait, which is hemoglobin A and hemoglobin S. Shows she is heterozygous for hemoglobin S. Her husband and father of the baby is also AS. What is the risk of her baby being homozygous SS sickle cell disease? All right, let's look at our handout. And we are going to look at autosomal dominant, autosomal recessive, X-linked recessive, and X-linked dominant. So the first thing we'll look at with autosomal dominant, do males and females both transmit the disorder? Yes. Are all generations affected? Yes. You don't skip generations. There are no carriers, and the diseases tend to be anatomic diseases that you can see by physical exam or X-ray. Achondroplastic dwarfism, Marfan syndrome, polycystic kidneys. Autosomal recessive, both male and female transmission, but all generations are not affected because you can have carrier states which will mediate. The parents can both be carriers but not know it because they don't have the disease. This is what I call the alphabet soup: CF, cystic fibrosis, TS, Tay-Sachs, SC, sickle cell, PKU, phenylketonuria, CAH, congenital adrenal hyperplasia. Then we have the X-linked. The X-linked recessive is not transmitted by both genders, only the female. All generations are not affected. There are carrier states, and these are female. And a good example of this is the hemophilia and color blindness. Females generally do not have color blindness or hemophilia, but they can be carriers. The X-linked dominant, there is only transmission by the, actually no, the female and the male can transmit it. I'm sorry, but, let me start again. There is no, there's only female transmission, but all generations can be involved. There are no carrier states. These tend to be lethal anomalies, and the patients will often die with vitamin D resistant rickets being a good example. So this is in your book, and it looks at the pedigree of autosomal dominant, autosomal recessive, X-linked dominant, and X-linked recessive. The squares are the males, the circles are the females. Those who have the disease and are affected are the solid. The X's are through those that have the carrier state. They're unaffected, but the closeness of genetics between the parents, or what is called consanguinity. These are the 2x2 tables which you use to calculate the X-linked recessive, or I should say autosomal risk, recessive risk. The most common Mendelian defect is autosomal dominant. That would be a good board question. Transmitted by both sexes, all generations affected, no carrier states. You can see this generation is affected, this generation is affected, this generation is affected. Every generation is affected, both males and females, and no carrier states. Autosomal recessive. Transmitted by both sexes, but can skip generations because there are carrier states, both males and female carriers. Here is dad, a carrier. Mom is a carrier. And you notice the double lines. the closer the genetics, the more likely that a couple is for both parents to be heterozygous carriers. And in that case, we have 50%, which are carriers of the children, 25% have the disease, 25% are neither carriers or the disease. But the autosomal recessive, it is estimated that each one of us have half a dozen lethal autosomal recessive genes. And so if we have children with a partner who has very similar genetics to us, the likelihood of these being expressed becomes higher and higher. And that's why in our society, we don't look with approval on a mother and son having sex or a father and daughter because of incest. They bring the genetics out in its worst way because those lethal genes have a higher risk of coming together. This is a tragic case of a British man who raped 2 daughters for 27 years. 19 pregnancies, 5 induced abortions, 5 spontaneous abortions, 9 births, 2 were stillbirths, and all of the 7 surviving all had genetic deformities. And that is the risk when you have consanguinity of closeness of the genetics. X-linked recessive, no male-to-male transmission, expressed only in males, female carriers, that's X-linked. And here we have the X-linked recessive. Now it's interesting, Queen Victoria was a carrier for hemophilia. And here is Queen Victoria. And who did she give it to? She gave it to her daughters. And the daughters gave it to their sons. And many of the sons of the czars of Russia died because of uncontrollable bleeding from hemophilia. Androgen insensitivity is an X-linked recessive. It affects only males. It is transmitted by the females. So these are genetic males. Now they don't look like males. Phenotypically they are female. Sexual identity is female. Sexual functioning is female. But from a genetic standpoint, they are male. We'll talk about this when I come back from Norway. X-linked dominant, you can see all generations are affected, both males and females. But what's interesting is mom can give to daughter and to son. But father can, or the son can only give it to his daughters. Because he gives his Y chromosome only to his son. And it's the X chromosome that has the problem. Okay, so that is Mendelian genetics. That is single gene disorders. Cytogenetics is single chromosome disorders. The last thing we'll look at here is multifactorial or polygenic inheritance. This is where you have many genes can give you the same phenotype. It's not a single gene such as with the Mendelian. Here's our case. A 32-year-old woman with corrected tetralogy of Fallot is pregnant at 18 weeks with a male fetus. She inquires as to the chance that her son has congenital heart disease. So what is the likelihood of a woman who has a multifactorial defect, which congenital heart disease is, of transmitting it to her offspring? And the answer is it's about 2 to 3%. The synonym for multifactorial is polygenic. More than one gene can give you the same phenotype. This is overall the most common cause of birth defects in the United States. The multifactorial polygenic. When you look at the Mendelian, the most common is autosomal dominant. But when we look at all of birth defects, it is most likely the multifactorial. This is the genes and the environment which are involved. You can heard this statement. The genes, how does it go? You have a revolver, or the genes load the revolver, the environment pulls the trigger. That's what I'm trying to say. So in order to have a multifactorial polygenic disease, you have to have a genetic predisposition, number one, and secondly, the environment which expresses it and it comes out. 2 to 3%. So here we have our genes. So you have to have a genetic predisposition. Here we have our physical, our environment. So the interaction in between is where the multifactorial diseases come out, where you have the genetic predisposition and the environmental which pulls the trigger, so to speak. You can see that neural tube defects, congenital heart defects, these are the most common multifactorial disorders. Cleft lip and palate, pyloric stenosis, and many adult chronic diseases, obesity, type 2 diabetes, cardiac disease, vascular disease, tend to be multifactorial disorders. So they are genetically given a predisposition. And then if a person has an environmental exposure, such as, for instance, obesity, the type 2 diabetes will be expressed. A type 2 diabetic who could lose weight and keep it off may very well become normal blood sugars and not have the type 2 diabetes. When we look at neural tube defects, the origin is between days 26 to 28 post-conception. It is a narrow window of time. If you're going to prevent neural tube defects, you need to have the preventive, whatever it is, on board in the mother's body between 26 to 28 weeks. Now, what is the intervention that we can do to decrease the risk of neural tube defects? Folic acid. Nada, you're right. It is folic acid. And if a woman is going to have increased folic acid at days 26 to 28, she has to start before she is even pregnant, because she won't even hardly know that she's pregnant at day 26 to 28. So it's important that we get this in her body early. Folate supplementation. This is the most common place for a spina bifida, which is in the sacral area, down the lower end of the spine. Now this is the worst kind of neural tube defect, which is where you've got anencephaly above the orbits. There is no cranium at all. This is a lethal anomaly. Now this is interesting, because here we've got not only anencephaly, but we also have omphalocele. Maggie, in the next few minutes, we're going to be going to the video of the uteroplacental insufficiency, so just a heads up. Prevention of neural tube defects is preconception folate. All women of reproductive age should be on 0.4 milligrams a day. If she is high risk, she should be on 4 milligrams a day, so 10 times higher. Now, folic acid is a water-soluble vitamin. You cannot get toxicity. It will run out in the urine. Now, who is at high risk for neural tube defects? These are in your notes, but let me just tell you. 1, type 1 and type 2 diabetics. They're going to be at risk. Women who take anticonvulsants, because anticonvulsants can decrease the absorption of folate. 3, a previous baby who is, had a neural tube defect. And 4 is family history of neural tube defects. So family history of neural tube defects, previous baby affected with neural tube defects, anticonvulsants, and type 1 and type 2 diabetes. Those are the women who should be on preconception folate before they even conceive. This is what you can do to decrease the neural tube defects with folic acid supplementation. Do you eliminate the neural tube defects? No, because you can't get rid of the genetics. But the folic acid can change the environment so you don't have the expression. Autoantibodies against folate receptors can cause neural tube defects. The antibodies. Folic acid slashes the risk of congenital heart disease. Adding folic acid lowers congenital heart disease risk, and this is something that we can do to decrease the risk. Okay, the number of birth defects from cytogenetic disorders is 1%, teratogenic is 1%, Mendelian is 15%, and multifactorial is 70%. So by far the most common one is going to be the multifactorial. Okay, I want to take a temporary detour and just talk about NSTs, AFIs, and uroplacental insufficiency. I don't want you to be writing this down unless you're really anal. Just want you to listen here, because we will come back and talk about this more later. I want to talk about uroplacental fetal unit and NST and AFI. First, we'll talk about the uroplacental fetal unit. This is an MRI of a uterus. This is a uterus. This is a placenta. This white is amniotic fluid, and this is the fetus. The uterus and the placenta and the fetus all together in one unit. Now what's interesting is this is the cervix down here. This is a placenta. What do we call this? This is placenta previa. And notice transverse lie. The fetus is transverse lie. We'll talk more about this later on. When you have a transverse lie fetus in the second and third trimester, you better think placenta previa. But anyway, what affects the uterus, affects the placenta, affects the fetus. Here's another. This is a color MRI. And the blue is amniotic fluid. This is obviously the fetus, and this is the placenta. And again, what affects the uterus, affects the placenta, affects the fetus. Okay, if we could have, Maggie, the video clip. And this is, I think, a very profound video clip because it looks at the uroplacental fetal unit blood flow and how important this is. All right, here we go. So this is a sagittal section through a pregnant woman, and here we can see is the spine, here is the aorta, and you can see the blood flowing down the aorta, through the iliac vessels, going into the uterus, and they come here through the uterus, to the placenta, there's a baby moving, through the umbilical cord, and to the fetus. Now, the little blue-green spheres are oxygen. And so what affects the blood flow through the aorta is going to affect the blood flow through the uterus, and it's going to affect the blood flow through the placenta. Now this is showing the intravillous space. And you can see the oxygen goes from the mom through the intravillous space through to the fetus. Now what happens to the blood flow through the intravillous space when there is a contraction? Okay, so we have the oxygen, which is the little green spheres, and the blue arrows is the carbon dioxide going the other way. And you can see the oxygen is coming into the fetus through the umbilical vein, and the carbon dioxide is going out through the umbilical arteries. All right, let's look at a contraction. There's a contraction. Relaxation. Contraction. Relaxation. Now let's look and see what happens to the blood flow through the intravillous space, which is right in here. Do you see where the contraction? The blood essentially stops flowing. Do you see that? So anything that decreases the blood flow through the mother's aorta, anything that decreases the blood flow through the uterus, anything that decreases the blood flow through the intravillous space, anything that causes decrease in blood flow through the umbilical cord is going to affect the blood flow to the fetus. So important. This is the basis of the contraction stress test. Okay, we can take that away, Maggie. This is the basis of the contraction stress test. With a contraction, the fetus is going to be stressed because it's going to have a temporary decrease in the oxygen. Can the fetus handle that? Okay. Okay, uteroplacental fetal unit. Perfusion is impacted positively by maternal physiology. We just talked about that in the first hour. The normal physiology and how it positively affects perfusion. But we're going to spend a lot of time talking about things that can impact negatively. Maternal systemic diseases, preeclampsia, chronic hypertension, diabetes, placental pathology, abruptio placenta, umbilical cord pathology, medications that the mother may take, substance abuse, all can go in a negative way on the fetus. All right, NST-AFI. NST stands for non-stress test. AFI is amniotic fluid index. These two together, the NST and the AFI, comprise the modified biophysical profile. We will talk more about this later on. The modified biophysical profile has two components, NST, amniotic fluid. Let's look at NST. When you hear the term NST, I want you to think of accelerations. I'll show you what those are. They are an increase in the fetal heart rate, temporary for a few seconds. They are stimulated by fetal movement and by scalp stimulation. Let me show you what scalp stimulation is. The cervix has to be dilated, obviously. The membranes must be ruptured, and you go like this to the fetal head. And you should see an acceleration of the heart rate. So this is a fetal monitor strip. Time goes this way here. Contractions, if there were any, would be shown up here, which there aren't any contractions. But here's a fetal heart. And you can see there is an acceleration, there's an acceleration, there's an acceleration. These are all accelerations. These are good. They are a response to FM. 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 What's FM? Fetal movement. If we see an acceleration, we know the fetus is moving. That is always reassuring. Acceleration. 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 We want to see the acceleration, amplitude of 15 beats a minute. We want to see the duration of the acceleration, 15 seconds or more. So we want to see 15 beats a minute increase, lasting 15 seconds or more. And that will be a reactive NST. Amniotic fluid. How is it assessed? It is assessed by either a single vertical pocket, which I will show you, or the 4-quadrant amniotic fluid index. So if the umbilicus is in the middle, here is the uterus. We divide the uterus into 4 quadrants and measure the deepest vertical pocket in each of the 4 quadrants. And let's say it is 5 centimeters plus 3 centimeters is 8, plus 4 is 12, plus 1 is 13. So the AFI would be 13, which is good. Here is a single vertical pocket of 2.4. Here's a single vertical pocket of 9.2 centimeters, and we'll talk more about these later on. So what we'd like to see is 2 centimeters or more for single vertical pocket. Urine, fetal urine is what makes the amniotic fluid. The baby pees. How does it get rid of the amniotic fluid? It swallows. It pees. It swallows. And normally that is held in a normal, good balance. Not too much fluid, not too little fluid. Now what happens if the fluid goes down? We wonder, is the urine flow decrease of the fetal kidneys is down? So it's an indirect evidence of baby not doing well. At least that's how we use it. And that's why we like to see normal fluid, we like to see accelerations. And that's what the modified biophysical profile is. And I'll talk about this over the next, today and tomorrow and after, when we look at the various complications of pregnancy. Okay, let's go now to chapter 2, which is pregnancy failed pregnancy. Failed pregnancy. Okay, we're going to look at induced abortion, early pregnancy bleeding, fetal death, fetal demise, and ectopic pregnancy. So, just a few words about induced abortion. I'm not going to get into the ethics. I don't know whether we'll ever, as a country, get to agree on the ethics, but we have the pro-life people, we have the pro-choice people, and everybody thinks that they are right. This is an Indian dentist who lived in Ireland who died of sepsis from ruptured membranes and chorioamnionitis on a 17-week pregnancy that she was not allowed to terminate. And she died, which to me doesn't make any sense at all. Mother's life certainly has to come before the fetal life. This you should know. This is abortion complications. This is advancing gestational age. And what this slide is trying to say is the further along when the pregnancy is being ended, the greater the risk of complications. So if you're going to do an abortion, do it early, don't do it late. Okay, this is in your handout, and we're going to look at DNC, dilatation and curettage, dilatation and evacuation, prostaglandin E, prostaglandin F2 alpha for labor induction, and hysterotomy. First, DNC. What is it? A DNC is aspiration of the uterine contents through a hollow cannula done in the first trimester, less than 13 weeks. Now, we need to dilate the cervix. You can dilate with either metal dilators or osmotic dilators called laminaria. I'll show you what that looks like. You can injure the cervix. You can get cervical lacerations from dilation. If you use the metal dilators, the laminaria are much better because they slowly dilate the cervix. And when you put an instrument in the uterus, you could perforate it. Most pregnancy terminations, abortions in the United States are DNCs, 90% or more. Once you get into the second trimester, 14 to 20 weeks, you can't suck out, aspirate the uterine contents. You've got to pull the fetus apart, more salation of the fetus. You have to dilate the cervix more, so greater risk of cervical lacerations and uterine perforations. But this is a surgical procedure that can be done in 30 to 40 minutes. It doesn't take a long time. This also is a surgical procedure. And those are the benefits of these ones. But do it early if you're going to do it, not late. Prostaglandin induction of labor is usually a second or third trimester issue where contractions are brought on by using prostaglandin E or F2 alpha. Those contractions over time will dilate the cervix and will expel the fetus. You can get so intense contractions from these that you get lacerations of the cervix, and you can get retained placenta, which of course can lead to hemorrhage and infection. Hysterectomy would be the most aggressive treatment where you would remove the uterus, a total abdominal hysterectomy. This can be done any time in the pregnancy. There's no dilation required, but the risks of hemorrhage, of infection, of injury to other organs is the highest because of the nature of the procedure. But I want you to look down here. This, I think, is really important. The risk of maternal mortality with the DNC is 1 per 100,000. But that's first trimester. When you get to second trimester, it goes up 4 times. 4 times higher in the second trimester. Induced labor with the prostaglandins, it is about the same as a vaginal delivery at term, 8 per 100,000. And hysterectomy is the highest risk of all, because often you use general anesthesia, and that has certain risks to it. The first trimester DNC, also known as vacuum curettage, you dilate the cervix, put this catheter in, attach it to a vacuum pump, and you basically just aspirate the uterine contents. The embryo, the placenta, the amniotic fluid, the membranes. This is the first trimester DNC. This is laminaria. This is made from seaweed. This is where it's dried out. This is where it absorbs fluid from the cervix and vagina, and you can see how it expands and dilates the cervix. This is a dry one. And this collar here prevents it from going in too far. These are the metal dilators that you can use. So basically, whatever the number of weeks of pregnancy, that's the number of millimeters you need to dilate. So here's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. You can see that an early D&C, you dilate the cervix much less risk of cervical injury than if you would have to use one of these for a D&E later on. Now, medical abortion uses mifepristone. Trade name is Mifeprex. Mifepristone is an anti-progesterone. So the way it works is it blocks the effect of progesterone, which is to prolong the pregnancy. It is used only in the first 7 weeks, so very early. It is used along with prostaglandin E1 or misoprostol. So we have mifepristone, misoprostol, the prostaglandin E1 brings on contractions, and 98% of the time, this is a successful expulsion of all of the uterine contents. But 2% of the time, you've got to do a D&C in order to successfully end the pregnancy. So that is sometimes called a medical abortion. It used to be called RU486. Mifeprex is the trade name, the early option pill. All right, we move from the first trimester to the second trimester and dilatation and evacuation. Here's a first trimester dilation. This is a second trimester, and you can see the D&E you need to dilate a lot more, so potentially more risk of cervical injury. This is the instrument that you use to grasp the fetal parts and essentially just pull them off. This is a gross procedure. And here you can see reaching in and pulling a leg and pulling it off. Now, you need to usually dilate the cervix more than this picture shows. But you've got to make sure that you've got all of the anatomy out. That the body, the spine, the thorax, the extremities, the head. It's a gross procedure, there's no question. But it is a surgical procedure. It is very quickly done, and it has half the risk of induction of labor in terms of maternal mortality. This was a fetus that had an anencephaly that I did a D&E on. I don't do them on live fetuses, but here you can see the feet, and here you can see the hands. I mean, this is a gross procedure. Labor induction, over time, the cervix dilates, and out comes the fetus. The benefit of this is if you need to do an autopsy, you have an intact body. If you do a D&E, all you have is fragments of the fetus. And hysterectomy is removing the uterus. Otomy is making an opening like a mini cesarean. And this is a major surgical procedure. We rarely use it, and the main indication would be invasive cervical cancer. And the idea is the mother going to die or will the fetus die? And here you can see the removal of an 18-week uterus with a radical abdominal hysterectomy for stage 1B cervical cancer. It's a real decision that is tough to make for the mom. Okay, so that is abortion. And this is in your book, very similar to what I told you before. And I think that's all we'll talk about that. This topic, however, is one which is very important, and it should be really called early pregnancy bleeding. A 40-year-old woman, gravida 3 para 1 AB1 at 9 weeks, comes to the office complaining of vaginal bleeding. How often do you think we see early pregnancy bleeding? Is it frequent or is it rare? Early pregnancy bleeding is quite frequent. I would say 15–20% of the time. Now, not all of these pregnancies will get lost, but many of them will, and those are most likely chromosomal abnormalities. So we got early pregnancy bleeding. A urine pregnancy test was positive 3 weeks ago. She initially experienced breast tenderness. However, it has now disappeared. She denies passage of any tissue vaginally. All right, let's look at early pregnancy bleeding. The most common etiology is a fetal problem. It is a cytogenetic. It is a trisomy 5, a monosomy 8. Major problems, so severe that you have embryonic demise. Now, you could have Mendelian causes, such as I talked to you about, lethal chromosomal abnormalities. These would be genes. There is, however, a rare syndrome called APS, antiphospholipid syndrome, where you can have multiple repetitive first trimester losses, however, a normal fetus, and this is treated with heparin. Heparin. All right, we're going to look at missed abortion, threatened abortion, inevitable abortion, incomplete abortion, and completed abortion. Let's look at our handout. So here we start. All right, notice down here in this little box, speculum exam, vaginal sonogram. Those are the two first things that we're going to do. The first thing we're going to do is a speculum exam. What are we going to look for speculum exam? Number one, we're going to look to see if the internal cervical os is closed, and two, we're going to look to see is there a lower genital tract lesion. Could there be a polyp that is bleeding? Could there be an ulcer? Could there be a laceration that is bleeding? If there is some sort of lower genital tract lesion, then you individualize the treatment to whatever it is. But let's say we do a speculum exam and the internal cervical os is closed. Now what is our differential? Missed abortion, which I would like to rename embryonic demise, that's really what happened, or threatened abortion. How do you determine which of these it is? Vaginal sonogram. Vaginal sonogram. If the vaginal sonogram shows a non-viable intrauterine pregnancy, empty gestational sac, or an embryo without a heartbeat, that's non-viable. You have three options. You can just observe and see if it'll pass on its own, give misoprostol, which is the prostaglandin E1, to induce contractions to expel, or you could do a scheduled D&C. We have what we call granola moms. These are women who are natural. They eat natural breakfast food, which is granola. I like granola too. But they want nature to take its course. That's okay. You can just observe. Woman says, I've got a busy office. I'm a lawyer. I need to see my clients. Can I have a D&C tomorrow? Sure. Schedule the D&C. So this is largely up to the woman. What if the vaginal ultrasound, and we use a vaginal ultrasound because in the first trimester the uterus is a pelvic organ. It's not an abdominal organ. You can see much better with a vaginal sonogram. If the vaginal sonogram shows a viable intrauterine pregnancy, most of these will usually go on and do well. Only one management, observation. So cervical os closed, missed abortion, threatened abortion. What if the speculum exam shows the internal cervical os is open? Now we have three options. Inevitable abortion, incomplete abortion, completed abortion. How do you tell which one of these it is? Vaginal sonogram. If the vaginal sonogram shows no POC passed, what's POC? POC is products of conception. Very good. If there is no products of conception passed, if the gestational sac is intact, but the cervix is opening, it's not a matter of will it happen. It is inevitable. It's going to happen. It's just how soon. The gestational sac is intact. Three options, observation, misoprostol, emergency D&C. Now, if she's see. What if the vaginal sonogram shows some products of conception passed, some remain in the uterus? That's what we call incomplete. Again, she could be a granola mom. We'll just observe, misoprostol, get contractions going, or emergency D&C. But what if the vaginal sonogram shows all the products of conception passed, nothing is left in the uterus, a normal endometrial stripe? Your options are one, only observation. So, let's review what we've said. There is one option with threatened abortion and completed, and that is observation only. There's three options with missed abortion, inevitable abortion, and incomplete, and that is either observation, misoprostol, or D&C. Okay, here is our granola. I love it. I have it every morning. But we do have granola moms who want things to... These are the ones who don't want vaccinations. They want to have just nature take its course. Okay? They don't want to intervene. Now, the next thing I want to look at is cervical os, open or closed. And this is the cervical os. You use a ring forceps like this. Can you pass it into the endocervical canal and the uterus without pressure, without resistance? If you can't, the cervix is closed. If you can go in, the cervix is open. So that's how you tell on a speculum exam. Sonogram. We used to do transabdominal sonograms, but with a pelvic organ, and particularly if you have an obese woman, it's hard to see. So now we use a vaginal sonogram. You put this wand into the vagina, and now you can see just as well if she is 400 pounds or if she's 100 pounds. Nice, smooth gestational sac. Here is the yolk sac. Here is a fetal pole. I like it. This is what you'd expect with a normal intrauterine pregnancy. You can use colored flow Doppler to show that there's cardiac motion. This is a 5 to 6 week. This is a 7 to 8 week pregnancy. So that's very helpful. Now, I love this. This is 11 weeks and 4 days. You can see that the skull is intact. We don't have an anencephaly. We don't have a spina bifida. The spine is perfectly beautiful. We don't have a ventral wall defect, no omphalocele or gastroschisis. We can see a mandible, a maxilla, and a nasal bone. Perfect. I love it. Beautiful. Now this is a nice, round, smooth gestational sac, but it is empty. Embryonic demise. Missed abortion. That's what this is. And can you see how this sac is starting to collapse? So cervix is closed, threatened abortion and missed abortion are our two options. Cervix is open, inevitable abortion, incomplete abortion. Now this would be a lower genital tract lesion like a cervical polyp. And you can see how that could bleed. So a threatened abortion can become a missed abortion can become an inevitable abortion can become an incomplete abortion, which can become a complete abortion. So where you happen to find it on the time spectrum may depend on what the diagnosis is, because early you may get a missed, and then it starts to dilate, but hasn't passed any tissue, becomes inevitable, and so on. But different diagnoses, but the same basic pathology. So that is our early pregnancy bleeding. You see the woman's face? On ultrasound, what you see depends a lot on your experience and do you have a trained eye. Okay, the second topic is fetal demise. This is fetal death. Have you seen a little casket at a funeral like this? Tragic. This has a significant impact on couples, the emotional conflict, and particularly with a wanted and desired pregnancy. Let's look at our case. A 28-year-old multigravida. At 33 weeks, comes to the office stating she has not felt her baby move for 24 hours. Now this is important. This is important. It's not decreased fetal movements. It's no fetal movements. If she says the baby's not moving as much, next step would be an NST. But when she says my baby isn't moving at all, that is an ultrasound. Yes, I did not have a picture of a missed abortion. No. I didn't have a completed abortion in there. Okay, an 18-week sonogram showed a single fetus with grossly normal anatomy. That was at 18 weeks. She's now at 33 weeks. You're unable to find fetal heart tones with a Doppler stethoscope. let's look at our handout here. The first thing I want to direct your attention to is the top left hand. I like to start there. What is the most common finding with a fetal demise less than 20 weeks? The uterus is less than days. What is the most common finding with a fetal demise after 20 weeks? No fetal movement. So those would be important, the clinical findings less than 20 weeks, the clinical findings over 20 weeks. Now the first thing you always need to do is to do an abdominal sonogram. Is there any cardiac motion? This is not a question. This is, you've got to do that. And with ultrasound, you can tell 100%, is it alive or is it dead? So, abdominal sonogram, once we get past the first trimester. All right, now, the least likely complication, but the one that you need to think about, is DIC. DIC occurs if you have prolonged retention of a dead fetus over 2 weeks. I would say even 3 to 4 weeks. And it is the tissue thromboplastin, which are released from the decaying tissue, that sets up a coagulation cascade that uses up clotting factors and platelets and performs DIC. But if you don't have a prolonged fetal demise, you're not going to see it. I've probably only seen a couple in 30 years. So this is very rare, but you should think of it if there is a prolonged demise. Now, what would suggest to you that there is a prolonged demise? Angulated spine. Gas in the abdomen of the fetus. See, normally you should have a smooth, round curve of the spine. When you have laxity of the ligaments, it's because they have decayed, and you can have a 90-degree angle, and I'll show you a picture of that. The laboratory findings are what will give you the information. Low platelets, high D-dimer, elevated fibrin split products, prolonged PT, prothrombin time, prolonged partial thromboplastin time. This is an OB emergency. You've got to move it. Now, there's only 2 ways of emptying the uterus. One is a D&E, the other is induction of labor. If it's less than 20 weeks, do a D&E. You're done in 45 minutes. Induction of labor can take 12, 18 hours. But if you're over 20 weeks, you can't pull the fetus apart. So that's why the gestational age will determine what you do. Okay, let's say DIC is not a problem, it's a recent demise. The next question is, and the questions to answer are in red, the red rectangles. Is the mom ready to empty the uterus? If she is not, if she is a granola mom, she says, I want nature to take its course, then fine. If there's no DIC, we can just watch. And we can do weekly DIC panels. Okay? What if she is ready to empty the uterus? The next question is, do we need an autopsy? And what will determine if you need an autopsy? Is there an abnormal fetus on ultrasound? Because if there's an abnormal fetus, you want to do an autopsy and see what's going on, and you need an intact body. If an autopsy is not needed, if the anatomy is normal, if it was not a history of abnormalities, then we can do a less than 20 weeks, a D&E, or if it is over 20 weeks, we would need to do a labor induction. Now let me just say this. If you do a D&E, it's going to be much harder to start the grieving process because there is no fetus for the mother to look at, to hold, to bury. So there are advantages of a D&E, but there are also limitations. If you've got a fetus that she can hold, that she can cry over, that she can name, and that has a lot of benefit in terms of grieving. What if an autopsy is needed? If an autopsy is needed, any gestational age, you always need to induce labor, prostaglandin. And you may want to do an autopsy, we talked about that. If you see that there is a short limbs, like dwarfism, you wonder if there's a skeletal abnormality, do a total body x-ray. If there is suggestion that there could be an aneuploidy, you can do a karyotype. Now, even if the fetus is dead, you can take an amniocentesis, and there are living fetal cells in the fluid that you can culture. If there is a fever, such as listeria, you can do a culture. And the Kleihauer-Betke test is looking for fetal blood cells in the maternal circulation, a fetal-maternal hemorrhage. All right, what are the questions? Number one, abdominal sonogram. Is there cardiac motion or not? Next, is DIC present? If that's not a problem, is she ready to empty the uterus? If mom is ready to empty the uterus, do we need an autopsy? Because that'll determine whether we do a D&E or labor induction. The gestational age is important because if it is over 20 weeks, regardless of whatever the indication, you've got to do an induction of labor because you cannot do a D&E. Okay, let's take our last break of the evening, and I will see you in 10 minutes. Okay, here we are for the last hour. And let's see if we can move on with the fetal demise. These are the questions you need to ask. The delivery mode. We already talked about this. A D&E is done if she is less than 20 weeks and if you don't need an autopsy. If she's 20 weeks or more and you need to get an autopsy, then we will induce labor because we need an intact body. All right? C, hold. We encourage the mom and dad to see the baby, to hold the baby, to name the baby, because it encourages the grief process. Now, you can't do this with a D&E, only if you have an induction of labor. And we talked about we need to find out, if we can, why it happened. The Rosette test is a screening test to see if there is fetal cells in the maternal circulation. The Kleihar-Betke is a quantitative test for fetal cells. And here you can see these fetal cells which are in the circulation. They're more darker and a little bit bigger. Okay, I'm going to show you some pictures of dead fetuses. Some of these are pretty gross, just to give you a heads up. This is the triploidy baby, 69XXY. These were 19-week IVF twins, a surrogate mom, ruptured membranes, prolapsed cord, preterm delivery before viability, but otherwise totally normal. Something's wrong with this baby. It's got most of the intra-abdominal viscera are outside. And notice the abnormalities in terms of the limbs. This was a trisomy 18 with a clenched fist. Is this a recent or a prolonged demise? When you see the sloughing of the skin, that suggests that you have been going on for some time. That's where you would start to think of a DIC. Notice the angulation of the spine. See, here's the head, and here's the body going up this way. You shouldn't have that severe angulation of the spine. This is a hydropic fetus, all swollen. We'll talk about that later on. Look at how hydropic this one is. This looks to me like a Turner syndrome. This is a outlet obstruction of the bladder with a mega bladder, huge abdomen. This is a osteochondral dysplasia, a dwarfism. Notice the shortened proximal and distal limbs. Same as this one. This is thanatophoric dwarfism. This is a good board question. What's the pathophysiology of how parvovirus B19 causes fetal demise? Most infections will cross the placenta, cause a vellitis in the placenta, cause a septicemia in the baby. Whereas with the parvovirus, what happens is the parvovirus destroys the red blood cell precursors, basically attacks the bone marrow, so the fetus becomes anemic, and the more anemic it gets, it goes into high output cardiac failure. That's the method by which parvovirus B19 works. Fetal demise at 34 weeks, fetus is footling breech. How are you going to deliver? Well, normally, if we have a live fetus in footling breech, we're concerned about the head getting stuck, so we say, let's do a cesarean. But when it's a fetal demise, if it takes an hour to get the head out or 2 hours, that's not a big deal. Let her have a normal delivery. Why have a cesarean with all of the risks for no benefit from the fetus? Now, here you can see this fetal head got stuck. Fold the body off of the head. Just wait. It'll come. Don't rush it. Fetal demise at 34 weeks gestation. Platelets are 70,000. Fibrinogen is 120. What's the problem? This is DIC. You need to end the pregnancy, pronto. At 34 weeks, you've got two options, cesarean or vaginal delivery. You can't do a D&E. And don't do a cesarean. I would induce labor. Induce labor. Okay, fix this into your hard disk so you can refer to this when you're taking an exam question, and I think you'll get any exam question correct. Ectopic. Ectopic pregnancy is the last one of this chapter. Pregnancy with implantation outside of the uterine cavity. The most common location is in the fallopian tube. The most common location in the tube is the distal tube. So here's our case. A 28-year-old woman visits emergency room with unilateral left-sided abdominal pain and vaginal spotting for 3 days. So she's got pain, bleeding. Last period was 8 weeks ago. She's got the triad for ectopic pregnancy. You need to remember that. Bleeding, pain, amenorrhea. She's used an IUD for 3 years in the past. Uterus is slightly enlarged. Could you have an enlarged uterus with ectopic pregnancy? Early in the pregnancy, you could, just from the hormones. There is left adnexal tenderness, but no mass. But the quantitative beta-HCG is 2600. Now that's going to be important. The beta-HCG titer, and we'll talk about that. This shows where does conception take place, and it's usually right around here. Watch this, right? Boom, right there. Anything that prevents the migration of the blastula to the uterine cavity will result in an ectopic pregnancy. And the most common location is in the tube. All right, let's look at our handout. The triad, the clinical triad for a ectopic pregnancy is pain, amenorrhea, and bleeding. What if she has that in the presence of hypotension, tachycardia? Your diagnosis has to be ruptured ectopic. Your management has to be get in there pronto, and I would say laparotomy to stop the bleeding. All right. She's not hypotensive tachycardic. She's stable. Always, whenever you have a female with vaginal bleeding, you better do a speculum exam to see if there is a lower genital tract lesion. We talked about that. Let's say that's going to be negative. Then we do a beta-HCG. If the beta-HCG is negative, she cannot have an ectopic because there's no trophoblastic tissue. We get a titer because we want to know how high the level is to know is it an advanced or an early ectopic. If the titer is above 2500, we should see an intrauterine pregnancy on vaginal sonogram if it is a normal pregnancy. But if there's a titer which is over 2500, no intrauterine pregnancy on vaginal sonogram, then we know we've got an ectopic. All right, lots of other causes of acute pelvic pain. There's 3 organ systems in the pelvis: the reproductive tract, GI tract, urinary tract, torsion of the ovary, acute PID, appendicitis, pancreatitis, pyelonephritis. Let's at least say that we have thought of those. Let's put those off to the side. All right. Beta-HCG over 1500, yes. Vaginal sonogram, no intrauterine pregnancy. If that's the case, then we've got ectopic. But what if the beta-HCG titer is less than 1500? Less than 1500. Then it is too early to tell, because it could be either a normal pregnancy that's too early to see, or it could be an ectopic. But if she is stable, let's just repeat the beta-HCG titer in 2 to 3 days, and what should happen? It should double. And then we'd be able to make the assessment. So you follow where we're at? Just repeat the beta-HCG titer and the ultrasound in 2 to 3 days. If the titer is over 1500, no intrauterine pregnancy, our diagnosis is unruptured ectopic. Now we need to know, is it early or is it advanced? We can use the beta-HCG titer as a assessment tool. If it is less than 5,000 to 6,000, we'll call it an early pregnancy. This can be managed with medical management using methotrexate. Methotrexate, what is the mechanism of methotrexate? How does it work? Methotrexate is a folate antagonist. Folate antagonist, it destroys any rapidly growing tissue. That can work very well in an early pregnancy, but if the beta-HCG titer is over 5,000 to 6,000, we'll call it an advanced pregnancy. This is surgical management, and this is a laparoscopy and we do most commonly a linear salpingostomy. Now, I don't think they're going to give you 5,000, 6,000. They will give you either 3,000 or they're going to give you 10,000. So they'll make it pretty clear. We need to do follow-up serum beta-HCG titers weekly until negative with both methotrexate, and if we do a linear salpingostomy, if we scrape out as much of the placenta as we could. But if you take the tube out, if you do a self-injectomy, you've removed all of the trophoblastic tissue, no need for serum beta-HCG titers. So, the steps in management. The first is a speculum exam, we talked about that. Second is a beta-HCG titer. Third is vaginal sonogram. Then medical or surgical management, depending on what the level of the beta-HCG titer is. Is it early pregnancy or advanced pregnancy? And then do we need to do follow-up titers? The most common location is in the ampulla of the tube. You could have a cornual pregnancy. You could have an abdominal pregnancy. What do you think? Is this Photoshop? Well, this was an actual abdominal pregnancy, implantation on the outside of the uterus. You don't need to do a cesarean because you don't need to open up the uterus, but take out the fetus. But don't try to remove this. Leave it in place and give methotrexate. All right, 100 patients who have bleeding. Let's see, do we have this here? No, that's gone. Okay, if you have a patient who is bleeding, you need to think of ectopic, threatened abortion, incomplete abortion, molar pregnancy. There is a single test which will tell us, is it ectopic, threatened, incomplete, or molar pregnancy? And what is that single test? It is ultrasound, sonogram. Exactly, you're right on track. Risk factors: anything which obstructs a normal zygote migration, scarring or adhesions, infectious adhesions from PID, post-surgical adhesions from tuboplasty or tubal ligation, congenital adhesions from DES, and a lot of the time we don't find anything. That's when we say idiopathic. Okay, here's what I was looking for. 100 patients with bleeding, amenorrhea, and pain. Only 10% have ectopic. But because it is the most severe complication, we need to assess that and rule it out. Beta-HCG titer over 1500, no intrauterine pregnancy, that's ectopic. The most common procedure is a linear salpingostomy. You can see we dissect out as much of the trophoblast. Then we do serial beta-HCG titers. If she is, say, 39, 40 years old, she will want you to take out the tube. Take it out. We're done. Here's my smallest patient. I opened up the tube on this patient who had an ectopic, and the heart was beating right here. How many women would like to have this implanted into them? Can't do it. 7 weeks. Okay, Maggie, we're going to be ready for chapter 3 coming up in just a minute. So secondary amenorrhea, unilateral pelvic pain, vaginal bleeding, that's ectopic. This is my granddaughter, at least one of them. And don't we look cute? I think she has my glasses on. I need hers. And who is this? Me. Okay, chapter 3. Let's go on to chapter 3, which is, I think, laboratory obstetric procedures. All right. All right, prenatal diagnostic procedures. How can we find out about the fetus prior to delivery? All right, let's look at our handout. And this has pretty well everything you need to know in one page. All right, CVS is not a local pharmacy. It is chorionic villus sampling. It is the earliest invasive procedure, done between 10 to 12 weeks. We aspirate placental precursors, what would become the placenta. And the reason we do that is because the placenta and the fetus came from the same origin, which is the zygote. So if we have normal placental chromosomes, we can pretty well infer that we have normal fetal. It is invasive, so there's a 0.7% pregnancy loss rate. There is first trimester non-invasive testing, which is done between 10 and 14 weeks gestation. There is no pregnancy loss because it is not invasive. We use ultrasound to look for nuchal translucency, NT. PAP-A, which is pregnancy-associated plasma protein A, and a free beta HCG. So this measurement of the nuchal translucency and these hormone levels are sent to a central lab, and they will do calculations and will give you a likelihood of abnormality. The most common invasive procedure is an amniocentesis done 15 weeks or more. We take cells which are floating in the amniotic fluid, which are alive from the fetus, called amniocytes, and we can measure amniotic fluid AFP, alpha-fetoprotein. There is a 0.5% pregnancy loss rate, so 1 in 200. The expanded AFP, used to be the triple marker screen, now it's the quadruple marker screen, is done between 15 to 20 weeks. The 4 tests are the maternal serum alpha-fetoprotein, the beta HCG, estriol, and inhibin. Because it is non-invasive, 0% pregnancy loss rate. This is probably the most common non-invasive procedure. The most common invasive is the amniocentesis. Sonogram is done between 18 to 20 weeks, the anatomy scan, non-invasive, and if you're only going to do one ultrasound, do it between 18 to 20 weeks. Fetoscopy is where you look into the amniotic sac with a fiber optic scope. You can make a bigger opening in the membranes. You can get ruptured membranes, bleeding, 3 to 5% pregnancy loss rate. The main reason for this is due to laser therapy in a TTTS. TTTS is twin-twin transfusion syndrome, and you could do a fetal biopsy. The last is PUBS, percutaneous umbilical blood sample, percutaneous umbilical blood sampling. This is done 20 weeks or more. What test can you do on umbilical vein blood? You can do chromosomes, you can do blood gases, you can do IgG, IgM, you can do all kinds of stuff. But it does have a significant pregnancy loss rate. OB sonogram, this is an abdominal sonogram. Mom can look at the same time as baby. Now transvaginal, first trimester, higher resolution, and the mom's BMI is irrelevant. The transabdominal is done second and third trimester. It is not as good resolution, and the mom's BMI is problematic if she is muy grande. The Doppler we'll talk about later on. The accuracy of first trimester ultrasound, at less than 9 weeks, it is really accurate, plus or minus 5 days. From 9 to 14 days is plus or minus 7, or 9 to 14 weeks is plus or minus 7 days. So early ultrasound is going to be the most accurate. Now here you can see 14 to 16 weeks, plus or minus 7 days, 16 to 22 weeks, plus or minus 10 days. The further along you go in the pregnancy, the less accurate is the ultrasound. Do you see that? Your early first trimester is your best, and your worst is later on. So if you have an early ultrasound, use that rather than a later one. Here's a nice fetal pole, nice round gestational sac. I can't see where the crown or the rump is, so I just call this a fetal pole. And here you can see the yolk sac. This is great. You already saw this before. I love it. Now we can have 3D ultrasound, and Maggie, if you could maybe get the next ultrasound ready to go here. You can see that there is a depth perception, which gives it aesthetic appeal, but it's not quite as good in terms of resolution. First trimester screening, we talked about the nuchal translucency, the PAP-A, the free beta HCG. This is the nuchal translucency. Can you see that measuring there? Here is a mildly abnormal. Here is getting more and more. Can you see how thick this is? And look at this one here. So the greater the nuchal translucency thickness, the more concern we have. Chorionic villus sampling, we go in through the vagina, in through the cervix, and we don't go into the amniotic sac, but we take it from the developing placenta. Amniocentesis, we put a needle in under ultrasound guidance, and we take out amniotic fluid. Amniocytes can be growing in there, and we can do aspiration and then do genetic testing on these cells. Percutaneous umbilical blood sample, we go for the biggest blood vessel, which is the umbilical vein. And here you can see the big vein right there. Fetoscopy, the most common reason is laser surgery in utero for twin transfusion. See, hardly any amniotic fluid, so we're going to zap the vessels. We're going to separate the circulations from these twins. Who's this? Moi. 1973. That's almost, gee, that's a long time ago. Where am I? Tahiti. Where am I? Tahiti. Okay, let's go to chapter 4. Is it true that amniocentesis and CVS are being replaced by free maternal DNA? That is absolutely correct. It isn't the standard of care, but it is being done more and more. But it's not as precise as the amniocentesis or the CVS. Okay, first prenatal visit. What is the first task of the first prenatal visit? Is she pregnant? Confirm the pregnancy. All right, how do we know she's pregnant? The most common way is a urine beta HCG. That's the most common and cheaper way. Fetal heart tones with a Doppler stethoscope would be great. I like to do ultrasound. Once you know she's pregnant, what's the next question? How far is she along? Date the pregnancy. Menstrual history, we'll talk about that. Clinical landmarks, we'll talk about that. Ultrasound, we talked about crown rump length, plus or minus 5 days at less than 9 weeks. Then are the risk factors, and we'll talk about obstetrical risk factors, medical, surgical, social, lots of risk factors, and these will have impact on how frequently we see the patient. If she's normal, low risk, no risk factors, we'll see her much less frequently than if she has risk factors. Laboratory tests we will talk about coming up. There are 3 groups that I use: tests for maternal benefit, tests for fetal benefit, and opportunity for immunization, and the scheduling of a return visit. If she's low risk, every 4 weeks up to 28 weeks, which is the end of the second trimester. In the third trimester, we will see her every 2 weeks until 36 weeks, and then every 1 week from 36 weeks until she delivers. Diagnosis of pregnancy. The most common evidence of pregnancy is amenorrhea. But are all amenorrheic women pregnant? Thank you, Lord. No, they're not. The most common sign of pregnancy is an enlarged uterus. Are all enlarged uteruses pregnant? No. Thank you, Lord. Beta HCG, we talked about that, a urine beta HCG, but the cheapest is just to listen for fetal heart tones with a Doppler stethoscope. Of course, I like sonogram. There are presumptive signs of pregnancy, probable signs of pregnancy, definitive signs. The presumptive are unrelated to the uterus or the fetus. The most common one is amenorrhea. Probable are related to the uterus or the mom's feelings, and beta-HCG and enlarged uterus is going to be the most common ones there. But the definitive is not a beta-HCG, because you could have a beta-HCG which is positive with a trophoblastic tumor of the ovary. Ultrasound of the fetus, sonogram, hearing the fetal heart tones, that is definitive. Establishing gestational age. Ideally, you were in the bedroom when sex is taking place. You know when conception occurred. Do we know that? Often we do. If there's in vitro fertilization, if there is artificial insemination, if there is embryo transfer, you know when conception occurred. Use that before any last menstrual period. The most common one that we use is the last menstrual period, but that depends because not all women have the same menstrual cycle length. Basal body temperature we will talk about. That looks at ovulation. The uterus size can be helpful, 8-week size, 10-week size, 12-week size. Of course, sonogram done very early is probably the best. Now, and I'm going to put this into a little different format, but it's exactly the same as this. Conceptional dating, when we know conception occurred, we will put a due date as 266 days or 38 weeks. Menstrual dating assumes that there's a 28-day cycle. And if that's the case, we will put our due date 280 days or 40 weeks from the last menstrual period. But not all women have 28-day cycles. The Nagel's rule is a cheap and quick way of calculating due date, last menstrual period, subtract 3 months, add 7 days. So if you start with July 4, subtract 3 months, we go 1, 2, 3, April, and then we add 7 days to 4, and so if her last menstrual period was July 4, we'll say her due date is April 11. Now this is a pregnancy wheel, and you can use this to calculate the due date. If this is the last menstrual period, this is when conception occurred, and if we are on July 17, she's going to be around 30 weeks, and her due date will be at 40 weeks, September 27. Not precise, because the length of the menstrual cycle can vary, but it's very helpful. This is in your book, and it looks at 4-week cycle, 3-week cycle, 5-week cycle. Ovulation on a 4-week cycle occurs on day 14. Ovulation on a 3-week cycle occurs on day 7. Ovulation on a 5-week cycle occurs on day 21. But notice the luteal, the post-conceptional phase, is always 2 weeks. 2 weeks. 2 weeks. And that is determined by the length of the corpus luteum, the lifespan of the corpus luteum. Okay, pregnancy dating. Basal body temperature, and here you can see the basal body temperature is at 97.7. Then it rises to 98.4, and the reason for that is the progesterone from the corpus luteum stimulates the thermogenic center of the brainstem and causes it to rise. Now this is not precise, but you can see it gives a pretty good indication of when ovulation would have occurred. Menstrual history tends to be reliable if it was definite, if it was normal, if it was a planned pregnancy. But that's not always the case. Some women are not really sure, and they're not very compulsive in keeping track. This is a large number of women who are ovulating, and their menstrual cycle, you can see the average, the mean, the mode, the median is 28 days. But you can have anywhere from 21 to 35 days and still be normal. But that's going to make a difference in your calculation of the due date. With a 28-day cycle, 21-day cycle, 35-day cycle, you can see that the ovulation always occurs here. Whoops. The post-ovulatory is always 2 weeks. So it's going to vary and this is conception and ovulation, will vary according to the length of the cycle. These are 3 women, all have the same last menstrual period, but look at the size of their fetuses. Very different, because this woman had a 35-day cycle, this woman had a 28-day cycle, and this woman had a 21-day cycle. So that's important to keep in mind in our calculations. Clinical landmarks. Early exam. What is the size of the uterus? 8-week, 10-week, 12-week. This is very much an educated fingers. Early fetal heart tones. Doppler, going to be important to hear. Quickening. When did the mom first feel baby move? Late fetal heart tones. This is heard with a fetoscope, not with a Doppler, and I'll show you what that looks like. After 20 weeks, we measure the fundal height with a centimeter rule. So 10 to 12 weeks, we can first hear fetal heart tones with a Doppler. That's going to be helpful to record. 18 to 20 weeks, fetal heart tones with a fetoscope. Quickening, the mom feels the baby move. 16 to 18 weeks with a multigravida, and 18 to 20 weeks with a primigravida. The multigravida, she knows earlier because she recognizes it. That's not gas, that's my baby. Whereas the first time around, she can't be sure. Here's a Doppler, and this is what we use to pick up the early fetal heart tones. Now this is a fetoscope. This is an obstetrician who is quite a bit younger than the one that I see looking in the mirror, but this is a Delis stethoscope. Okay, this I believe is the next ultrasound. Can we put this one on, Maggie, and see if this is the one that I think it is? This is the fetal movement one. Well, okay, this is 3D or 4D ultrasound. And you can see it is not only depth, but you can see the motion. Now look at this kid move around. Arms and legs and head, extension of the head. Look at these extremities here. Very good, isn't it? Baby doing exercises in utero. You can see the anterior fontanelle right up on the top of the skull. Okay, we can take that one away. Fundal height. After 20 weeks, the fundal height should measure in centimeters the number of gestational weeks. So the uterus is a pelvic organ up to 12 weeks. So you can't measure. At 20 weeks, it should be about the umbilicus. At 16 weeks, it's midway. So it's not going to be 16 centimeters. It's only after 20 weeks that we measure with a centimeter ruler. And here we are measuring. Now here's a woman who is 20 weeks. You'd expect her uterus to be here. So how come it's up here? Well, the reason is simple. She has triplets. And here they are. And they're all boys. So when you use the 20-week umbilicus, that's got to be with a single fetus. Ultrasound dating. Crown rump length is what we use in the first trimester, CRL. And this is a nice crown, nice rump. And we talked about the accuracy of a crown rump length. Second trimester, we use the biparietal diameter, head circumference, abdominal circumference, femur length. This is the head circumference. This is the biparietal diameter. This is the abdominal circumference, and this is the femur length. So here is the head, circumference, biparietal diameter. This is probably best for pregnancy dating because you can always see the skull. The abdominal circumference is going to be much more problematic. This is the stomach right here, And this is probably best for estimating fetal weight. So the biparietal diameter for dating, fetal weight, abdominal circumference. Femur length is pretty easy to see because it's bone. So we measure each of these 4 diameters, and then we average them out to give an average ultrasound gestational age. And the accuracy we talked about. If a patient is low risk, we will see her as we talked about, monthly to 28 weeks, 28 to 36 weeks, every 2 weeks, every week from then on until delivery. Now, if she's got risk factors, diabetes out of control, hypertension out of control, hyperthyroidism, obviously we're going to see her more frequently. All right, normal pregnancy events. They may ask you on the exam a question, and your answer is, I'm going to do nothing. Because their normal events are so common that they're managed conservatively. When we talk about trimesters, which we're going to talk about, they really don't have a whole lot of biological significance. All they are saying is, first trimester is early, second trimester is middle of the pregnancy, third trimester is the latter part of pregnancy. That's really all it's saying. So let's look at our handout. First trimester, the most common symptoms, nausea and vomiting. If a woman doesn't have nausea and vomiting, you say, what's wrong with you? This is not hyperemesis, but this is so common. What do? You manage conservatively, crackers, small amounts of water, avoid food that makes it worse. What if there's vaginal bleeding? Ultrasound shows a normal pregnancy, cervix or the speculum exam shows the cervix is closed. Nothing. It's managed conservatively. Weight gain is 5 to 8 pounds. The main reason for this is because of the increase in plasma volume. Complications, spontaneous abortion. The most common reason for the complication of spontaneous abortion is aneuploidy. What can you do to change that? Not a whole lot. Second trimester, quickening. That's just mom feels a baby move. We don't do anything about that. Braxton Hicks contractions, and by the way, Jose, this is Dr. Braxton Hicks, one of the old obstetrical gurus. Braxton Hicks contractions start as early as 14 weeks. They have low frequency, low intensity, long duration, and they don't change the cervical dilation or effacement. You don't do anything. You manage them conservatively. In second trimester, the main risk or complication is cervical insufficiency, which we'll talk about later. But really, the second trimester is usually pretty unremarkable. The third trimester, lightening. This is where the baby drops, and now the mom can breathe easier. Management, conservative. Bloody show. What is a bloody show? This is a uterus. This is an amniotic sac. This is the cervix. This is the cervical canal. This is the vagina. There are mucus-producing glands in the endocervical canal. As the cervix starts to dilate, mucus and blood can be released. Not bleeding, but just bloody mucus. It doesn't mean that she's in labor. All it says is she's starting to dilate, and the management is really conservative. You don't do anything. Now we have complications, premature rupture of membranes, preterm labor, pregnancy-induced hypertension, gestational diabetes, and so on. So those would be fairly common, and we would just manage them conservatively. All right. In terms of weight gain, normal weight, 25 to 35 pounds. Underweight, gain more. Overweight, gain less. And of course, with twins, gain more. But you don't need to memorize these. 25 to 35 is normal. Okay, I think we're going to get to the end of chapter 3. If you could have chapter 5 ready, because I think, yeah, we may just get that. Okay, safe and unsafe immunizations. The main thing to remember is that if it is a killed or inactivated organism, it's safe in pregnancy. It's safe. Influenza, all women who are pregnant should get a flu shot. The other ones are really only for specific indications. So the main safe immunizations that we should give is the influenza for all pregnant women. The unsafe are either a live or an attenuated virus. Measles, mumps, polio, rubella. We don't give rubella during the pregnancy, we give it after delivery. Yellow fever, varicella. This is one which is really quite new from the CDC, and this has to do with Tdap, which is the tetanus, diphtheria, acellular pertussis vaccine. And here's what the CDC recommends. Tdap to all pregnant moms, irrespective of the patient's prior history. When you give it, ideally between 27 and 36 weeks, and you're trying to give antibodies to the baby so that it will not get pertussis, which we've seen breaks, vaccine has not been given. And so we have these outbreaks, like there was one at Disneyland. This is what the granola moms would say, I don't want to get the Tdap. For women not previously vaccinated, if Tdap is not given during the pregnancy, give it immediately postpartum. So we want to give the flu vaccine and we want to give the Tdap. Okay. Let me just answer one question here. Amniocentesis is being replaced by free maternal DNA testing. This is something which is coming on the horizon. This is fragments of fetal placental DNA which are in the maternal circulation, can be picked up as early in the first trimester. They have a very high specificity and sensitivity, but it's not 100%. It's like 98%, but it is not high enough to use it as a definitive diagnosis. For many women who are granola moms who don't want to have an invasive procedure, this is an appropriate one to do. But we do not do it routinely, and I don't believe they're going to be asking you this on the exam either. Okay, this is my wife, Daryl Lee. Where are we? Anybody know? Yes, Laura, it is in Rome. And what area in Rome is it? Plaza España. Okay, it is the Spanish Steps. Right, so it is. Okay, very good. Let's go on to 5. And tomorrow, when we start, I'll have some questions for you. We'll do some cases. So look over what we went over today. Okay, prenatal laboratory testing. Here's our case. A 21-year-old gravida 1 pair 0 presents for a first prenatal visit at 11 weeks, which is confirmed by the OB sonogram. If she has a OB sonogram that confirms 11 weeks, that is very accurate, plus or minus 7 days. No risk factors. Okay, what laboratory tests are we going to use? So let's look at our handout. I'm going to look at it from 2 viewpoints. The first is, what is the diagnosis we're looking for? First trimester, we're looking for anemia. What's the most common anemia in pregnancy? The most common anemia in pregnancy is iron deficiency. Exactly, iron deficiency, folate deficiency. So how do we do that? What's our testing that we do for that? CBC. CBC. All right, we want to screen for infections, and there's 5 sexually transmitted diseases that we want to look at, and a urinary tract infection. The screening test we're going to use for urinary tract infection is a urinalysis, looking for white cells and bacteria, and a culture. The 5 STDs are chlamydia, gonorrhea, hepatitis B, syphilis, and HIV. Those are the 5 STDs that we want to screen for. We don't screen for herpes. Rubella, what are we going to look for? We're going to look for rubella IgG antibody, positive or negative, susceptible or immune. And if she is susceptible, we'll give her an immunization after pregnancy because it is a live attenuated virus. Then we want to look at, is the mother developing antibodies against foreign red blood cell surface antigens? is she sensitized to other antibodies? And that test will be the indirect Coombs test or atypical antibody test. And we'll talk about these all in detail. The second trimester, the screening is really the expanded AFP or the quadruple marker screen. The quadruple marker screen involves maternal serum AFP, beta HCG, estriol, inhibin A. The third trimester, we want to look for gestational diabetes. We're going to talk about that probably when I get back from Norway, so we're not going to talk about that now. Rh immune globulin, we're going to talk about under isoimmunization, so I'm not going to talk about that right now. Group B strep, we will talk about under perinatal infections, so I'm not going to talk about that now. But these are done, gestational diabetes, 24 to 28 weeks. ROGAM is going to be around 26 to 28 weeks, and group B strep is 34 to 36 weeks. All right, the last thing I want to cover today is the three groups of prenatal tests, and I'm going to look at it not from what the diagnosis is, but who is going to benefit from this. The first one is maternal benefit. CBC, we're going to look for early diagnosis and treatment of iron deficiency and folate deficiency anemia. If the mom is iron deficient, is the baby iron deficient? No, there's active transport across the placenta, so this is primarily for maternal benefit. And treatment of asymptomatic urinary tract infection. What is the impact of a maternal urinary tract infection on the fetus? Nothing. This is primarily for maternal benefit. Pap smear would be done if it is appropriate for her screening, and we'll talk about that later. Diagnosis and treatment of cervical intraepithelial neoplasia. What's the impact of CIN on the fetus? None. This is primarily for maternal benefit. Now, the cervical cultures for gonococcus, GC, and chlamydia, that is for both maternal and fetal. Sickle cell, I really should take out of here because it's not a routine test. But when we look at fetal benefit, the isoimmunization, the atypical antibody screen, that is primarily for fetal benefit. The mother is going to be negative for the antigen. She will never attack her own red blood cells, but it's the fetus that is at risk. We talked about the GC and chlamydia, the cultures. That's going to be for both mom and baby. Now, RPR is looking at the screening test for syphilis to prevent congenital syphilis. And here's the deal. Primary syphilis is very seldom seen. Secondary syphilis is not usually seen. We usually pick up syphilis in pregnancy during the latent phase. And the latent phase is where the mom just sits there. There's no guma. There's no tertiary syphilis. And she really is not going to have any problems. But who is at risk? It's the fetus. That's why even if a mom has latent syphilis, we treat so that we can prevent the fetus from getting syphilis. Now, gestational diabetes. What's the purpose for screening for gestational diabetes? It's not because of the impact on the mom. The mom isn't going to develop renal disease or a retinal disease. It's the baby that can become macrosomic. That's why we do screening for GDM. HIV screen. Most of the time, if mom is HIV positive, she has a normal CD4 count and she has an undetectable viral load. If she was not pregnant, we wouldn't give her antivirals. But the reason we give antivirals is not for maternal benefit, but prevent congenital HIV. The rubella is to immunize the mom after delivery, if she is rubella sensitive. Hepatitis B surface antigen is given to the baby if the mom is surface antigen positive to protect the baby. And ROGAM is given at 28 weeks. See, these are all immunizations. And immunizations are all primary prevention. All of these ones are secondary prevention. These ones here are the only ones which are done for primary prevention. Okay, next or tomorrow we will meet and we will start off the day with a whole bunch of cases. and I think you will enjoy that. And then we will continue on, and I would like to do up to chapter 8 or 9 tomorrow of OB. So, thank you very much. Thank you, Maggie. Thank you, Dr. France. And, hey, you have a good evening. I'm only 7 o'clock, but you guys are going to be going to bed soon. And have a good evening.